मैंने मैंने भी वो स्क्रीन भी ज्वाइन कर साथ में लगा लिया है, वो भी खोल लिया है दूसरा स्क्रीन।
देखो अब आ रहा होगा।
सर अभी नहीं चाहिए।
अब आया।
हाँ अब आ गया।
स्क्रीन भी ज्वाइन कर साथ में लगा लिया है, वो भी खोल लिया है दूसरा। अच्छा, टाइम डिले। अब आया।
हाँ अब आया।
स्क्रीन ज्वाइन कर साथ में लगा लिया है, वो भी खोल लिया है दूसरा। अच्छा, टाइम डिले।
सर वो म्यूट कर दीजिए यूट्यूब को।
हाँ। अब आया। ज्वाइन कर साथ में लगा लिया, वो भी खोल
ये क्या दोनों उसी पर लगाएं क्या?
जैसे अलग
YouTube भी?
अलग स्क्रीन पे।
तो
अरे वाह, वेलकम महेश भाई, डॉक्टर महेश मोहिते। So sweet to have you.
Good evening, sir. Good evening.
हेलो।
Thanks for giving this.
आपसे सीख रहे हैं। आपने तो इतनी जबरदस्त सीरीज शुरू की थी।
Yeah.
कुछ कुछ टॉपिक्स आपको लेंगे और वो एंटीबायोटिक वाले टॉपिक में आपको बुलाएंगे।
बिल्कुल आएंगे, बिल्कुल आएंगे। अच्छा,
ये बेसिकली हम लोगों ने शुरू की है जो छोटे शहरों में प्राइवेट प्रैक्टिशनर्स हैं उनके पॉइंट से जो डे टू डे प्रॉब्लम्स रहती हैं, इश्यूज रहते हैं,
yes,
उनको एड्रेस करने के लिए।
absolutely.
नमस्कार महेश जी।
नमस्ते, नमस्ते।
छोटे छोटे शहरों में क्यों, बड़े शहरों में भी वही प्रॉब्लम रहती है।
Absolutely,
बड़े
absolutely.
रहनों में सर इनके पास रिसोर्सेज ज्यादा है ना। कल दीपक कह रहा था कि वी कैन हैव। अरे वाह नीली, हाउ आर यू? सो स्वीट,
हेलो।
दैट्स ग्रेट, थैंक यू डियर।
Hello, Nelly. Unmute,
सो
unmute.
स्वीट।
Dr. Nelly, unmute yourself.
साहब
Yeah.
साहब साहब गुड इवनिंग साहब। बड़े साहब गुड इवनिंग। महेश भाई गुड इवनिंग।
Good evening.
अशोक बंगा साहब,
नमस्कार।
दास भाई, करण दीदी।
गांधी वेरी गुड इवनिंग।
गांधी जी अनम्यूट कर लो।
साहब 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 ठीक है सर।
ये नीली से इंस्पायर हुए सर। आपको पता है नीली आफ्टर 35 years of practice has joined pharmacology to learn. He is doing MD in pharmacology
अरे वाह
from medical college
ओह,
as a regular student.
वाह वाह वाह।
मैंने उनका फोन नंबर ढूंढ के निकाला और उनको फोन किया कांग्रेचुलेशन करने के लिए। मैंने ये भी
हाँ।
बोला कि मैं ये कभी सोच भी नहीं सकता हूँ।
साहब
This is absolutely extraordinary, extraordinary.
अनूप भाई वेलकम।
नमस्कार।
क्या बढ़िया
कटकर
बीच
सर
पे बैठे हुए
नमस्कार।
हो आप।
नमस्कार सबको।
सर कटकर सर
अच्छा,
नमस्कार। धीरेन भाई
नमस्ते
नमस्कार।
सर,
नीली
कैसे
भाई
हैं?
अरे गांधी साहब भी है। बांगा
धीरेन
सर
वेलकम।
सर
तुम जब
अच्छा महेश
स्पीकर
भाई
बन के आते हो तो बड़े
महेश
सूट बूट में टाई में होते हो, जब गेस्ट बन के आते हो तो बढ़िया पीछे सीनरी लगाते हो।
नहीं नहीं
नो
सर,
गुड।
हमारे पास तो हम तो गरीब लोग हैं, एक ही कमरा है।
आज थोड़ा संडे वाला मूड में है धीरज जी।
कितना बढ़िया बढ़िया सूट पहनता है जब ये स्पीकर होता है तो। बढ़िया टाई शाई और सूट एकदम इम्पोर्टेड वाले।
अच्छा, वैसे तो मूंछों से ही इतना लोभ पड़ जाता है कि सूट की जरूरत ही नहीं होती। तो दोनों हो गए। ये दोनों मूंछों वालों पे लागू होता है।
ये बताओ कलर्ड है कि ओरिजिनल है?
नहीं ओरिजिनल है पर कलर्ड है।
करुणेश एक बार उनको और फोन कर लो, डॉक्टर विनीत भूषण को और डॉक्टर अजय गौड़ को। सुहास तो आ गया, तो लेट अस स्टार्ट इन टाइम।
अच्छा डॉक्टर विनीत हेलो।
हाँ विनीत भाई जय हो।
नमस्ते सर, कैसे?
नमस्कार।
बड़ी बढ़िया बैकग्राउंड। आप तो गोवा गोवा में बैठे लग रहे हैं, बढ़िया हवा चल
नहीं और नॉर्मल बैकग्राउंड।
हाँ वही तो कह रहा हूँ, गोवा का अच्छा बैकग्राउंड डाला है।
और बढ़िया हवा चल रही है, पेड़ भी हिल रहा है।
नमस्ते सर, कैसे हैं? कैसे डॉक्टर साहब? वेल,
सर नमस्कार, विनीत गुप्ता जी नमस्ते।
नमस्कार सर, नमस्कार डॉक्टर साहब। बताइए, सब बढ़िया चल रहा है एकदम से?
कैसे?
सन
हाँ,
दोपहर
सीपी तुम बताओ तो फिर
दीपक
अपन
भी आ
शुरू
गया।
करें।
दीपक, गुड आफ्टरनून। हाँ सर, शुरू कर दीजिए प्लीज।
इवनिंग सर।
चलते
नमस्ते।
दीपक भाई।
सभी उपस्थित महानुभावों को मेरा प्रणाम। ग्वालियर एकेडमी ऑफ पीडियाट्रिक की तरफ से आपका सब स्वागत करता हूं। मुझे बहुत खुशी है कि इस वेबिनार में शामिल होकर आप ईजी के बारे में जानने को उत्सुक हैं। मुझे पूर्ण विश्वास है कि यह सत्र आपके लिए दिलचस्प होगा। ज्ञान दीपक ज्योति जलावे, अज्ञान तिमिर सब दूर बढ़ावे। ज्ञान की शुद्ध अग्नि की ऊर्जा हमारी चेतना, बुद्धि और ज्ञान के माध्यम से प्रज्वलित रहती है, जिससे हम विज्ञान को बेहतर समझते हैं और इसका उपयोग जटिल समस्याओं का समाधान करने में करते हैं। हमारी दैनंदिन प्रैक्टिस में सीजर्स के कई मरीज आते हैं। आजकल एविडेंस बेस्ड प्रैक्टिस में हमारे लिए कई टूल्स उपलब्ध हैं, जिनमें से ईईजी एक नॉन इन्वेजिव टूल है जो हमें कई तरह की जानकारी देता है और सब जगह सुलभ है। आज इसी विषय पर हमारे मुख्य वक्ता हैं डॉक्टर अनूप वर्मा जी, जो हमारे देश के विख्यात न्यूरोलॉजिस्ट माने जाते हैं, और चेयरपर्सन हैं डॉक्टर विनीत भूषण गुप्ता जी। हमारे ग्वालियर के गौरव डॉक्टर दीपक उग्रा और धीरेन गुप्ता विशिष्ट अतिथि के रूप में उपस्थित हैं। मैं तहे दिल से आप सभी का पुनः स्वागत और अभिनंदन करता हूं और कार्यक्रम आगे बढ़ाने के लिए आमंत्रित करता हूं हमारे पूर्व प्रेसिडेंट डॉक्टर सीपी बंसल को। डॉक्टर सीपी बंसल।
Thank you, respected sir. My very sincere, respectful regards to especially Dr. Bakul Bhai and all esteemed guests present here. Friends, let me first welcome you all to Gwalior webinar episode 2. Today, we will be definitely dwelling on a very practical issue. Understanding EEG in office practice, you will all agree with me, is crucial. Yet, we all face challenges when relying solely on reports. Today, we bring you an insightful session to unravel these complexities and provide clarity on EEG interpretation in real world scenarios. We are honored to present Dr. Anoop Verma, a clinician par excellence, whose contributions to pediatric neurology are truly remarkable. An esteemed author of various books ranging from humor to all technical subjects in pediatrics. Eh, We all know his series of clinical spotters, and even today he has released question number 105. We admire that and really enjoy it, Anoop Bhai. He is also a legendary photographer and also a traveler. Many of you might not be knowing these qualities in his life. He is curating a world-class collection of neurology motion disorder videos. Having served as chairperson of neurology chapter of IAP, he is an extraordinary orator, and it is really a privilege to welcome him to Gwalior webinar today. Guiding our discussions today is our esteemed chairperson, a very close friend of mine, Dr. Vineet Bhushan Gupta, a leading pediatric neurologist trained in UK and now practicing in Apollo Hospital, New Delhi. We also extend a warm welcome to our special guests today, Dr. Deepak Ugra and Dr. Dhiren Gupta, both hailing from Gwalior and a source of immense pride for our community. We are delighted to have them with us today. To all our viewers, thank you for joining us. Your participation make this dialogue impactful and valuable. We look forward for an engaging and enlightening session. My special mention of the presence of my very close friend Dr. Neeli Ramchandar, apart from Dr. Bakul Bhai, Dr. Gandhi, Dr. Ghanshyam Das, and I must be failing if I don't mention the name of Mahesh Mohite, a truly inspiring person in this field of topics, and we will be having, as we have already promised, him and Bakul Bhai in one or two series later on antibiotics. If I call Bakul Bhai as father of this, it will not be wrong. We are present here today because he started all this e-platform and webinar series during COVID when he was president and started DIP. Bakul Bhai, you will be really happy to know that it is all indigenous. We have made our own YouTube channel and we are ourselves doing it live on YouTube. We are not taking help for this from any professional as far. So,
Congratulations. Yeah.
thank you so much. I'll not take much of your time in between. Over to Dr. Ketkar, sir.
Unmute, sir. Unmute, sir. Dr. Ketkar, please unmute.
I request Dr. A.K. Banga brief introduction of Gwalior webinar and its mission.
Namaskar. For many months, we have been thinking, why don't we have our own a digital platform where we can discuss the clinical problems of our city and the main topics, and we can take help from all the experts in the country. We wanted our PGs and the young pediatricians of the city to take over this program. But somehow they are struggling to establish themselves. So they don't have that much of time. So finally, after waiting for about 6 months, we, the people in 7th and 8th decade of life, thought of starting this thing. Maybe the younger generation will take it over further. So we thought of having one program a month. But good thing is that within first week, this is the second program that we have. So mission is to discuss the clinical situation with experts and learn what if we are in the 7th decade or 8th decade of life. Learning is a continuous process and we must keep on learning always. So this is the platform for that. After this introduction, I'll request Professor Ajay Gaur to introduce and honor our chief guest and our speaker of the day, Dr. Ajay Gaur.
So good evening, sir, and good evening to all the viewers of this webinar, Gwalior webinar series. And I must congratulate the Gwalior Academy of Pediatrics and the brain behind this, our respected Professor C.P. Bansal, sir, for having this
Anoop,
Gwalior webinar and
हाँ जी,
series for all of us. And as far as the introduction of
मैं
Anoop
किसी
Verma, I
मीटिंग
think
में
the
हूँ
Anoop
मैडम, बात
Verma is a
करते हैं.
very well-known figure across the country, and he doesn't need any introduction. And he is just like our big brother for the Gwalior Academy of Pediatrics. And I personally feel that he has a lot of spotters and quiz and videos and everything is in his pocket. So even if when we are struggling with any clinical scenario, so we are talking to him, and he is so helpful all the time that he is always helpful for the even a single person can send him a video. He is just giving very promptly, giving the answer and helping him out. And apart from his all the credential which Dr. CP Bansal sir already narrated, uh, I also welcome the second the chairperson of today's Dr. Vineet Bhushan Gupta in this webinar. Sir is senior consultant from Indraprastha Apollo Hospital, New Delhi, and sir rightly said, Bansal sir, ki he is trained from the UK. He did his MRCP from UK, and he is a member of Royal College of Pediatric and Child Health, and is a special interest in the management of difficult epilepsy, CNS infection. So I think we have a very long interaction even after this webinar with Dr. Vineet Bhushan in future. Thank you very much. I welcome all the respected seniors across the country, and all the fellow colleagues of the Indian Academy of Pediatrics for joining this webinar. Over to Sir Panga, sir.
Thank you, Ajay. I request Dr. Suhas to welcome our special guest, Dr. Deepak Ugga and Dr. Dhiren Gupta. Dr. Suhas, please.
Yeah. Thank you very much, Banga sir. Welcome, Deepak. Welcome, Dhiren. It is indeed a matter of proud privilege for me to welcome two Germans in this wonderful meeting. Both of them are pride of Gwalior. So, Dr. Deepak Ugra was the national president in 2010. I was the executive member then. So it was indeed a privilege for me to be working with Dr. Deepak Ugra way back in 2010. He is a DNB and RCPCH examiner and trainer. Has delivered umpteen number of guest lectures almost all over the country and has many friends. He has a good habit of making wonderful friends because he responds so very warmly to each one of them. He is right now a consultant pediatrician in Lilavati Hospital and the PD Hinduja Hospital, Mumbai. He is also an international council member of RCPCH, Royal College of Pediatricians and Child Health for 2024 to 2027. He is also a founder trustee and founder trustee of research and education in child health. Welcome, Deepak. Dr. Dhiren Gupta is a name that almost everybody knows since COVID days, very difficult days, where he purely showed his mettle to everybody by helping all those who asked for and also those who didn't ask. He was advising almost everybody. He is the co-director PICU, Pulmonology, Allergy and Emergency at the Gangaram Hospital, New Delhi. He recently has done diploma in European Respiratory Medicine and Medicine Allergy Asthma Specialist course Meditrain co-director. DPAA, he is a teacher and PICU fellowship, focus teacher and trainer. Teaching, though not in a medical college, has been his obvious habit that he has been displaying almost each one of us, helping almost each one of us, especially during those difficult COVID days. Mostly used his understanding in the management of COVID to everybody's health. Welcome, dear Dhiren. You're most welcome. Over to Banga sir. Unmute.
Thank you, Suhas. Finally, the moment has come when we welcome the keynote address. Now, Dr. Anoop, now stage is yours for next 45 minutes.
Sir, am I audible, sir?
Yeah.
Am I audible, sir?
Yes, you are audible.
Yes, sir.
Yes.
Just before my presentation, I would like to convey my regards and greetings from Chhattisgarh, Raipur. And it is my privilege really that three national presidents are honoring the stage, Dr. C.P. Bansal sir and Bakul Parekh sir and Dr. Deepak Ugra sir. And it is both an honor and a privilege to hear today addressing such a distinguished audience. I would like to begin by expressing my heartfelt thanks to the organizers of this wonderful events, especially Dr. C.P. Bansal sir, who whose relentless dedication to academics has always been a source of inspiration. Dr. Bansal sir, your unwavering commitment to the advancement of pediatric knowledge and your constant support to me in both academic and organizational endeavors are invaluable. I am truly grateful for the opportunities you have provided me in the past and continue to extend to me today also. Just a few words for you, sir. A true leader's legacy is not measured by the height they reach, but by the foundation they built for others to rise upon. Dr. Bansal's unwavering commitment to academic excellence and the growth of pediatric knowledge has not only shaped the present, but will continue to inspire future generation of pediatricians for years to come. Gwalior has always held a special place in my heart. Coming from an undivided Madhya Pradesh, this city feels like my own. Over the years, I have had the privilege of delivering several presentations here, and each time I am amazed by the academic vibrancy that this city offers to me. Gwalior is not a city, it is not a state as well. It is a national academic hub, a beacon of knowledge and learning for pediatricians across the country. This is a direct result of visionary leadership of Dr. C.P. Bansal and the entire team of academic luminaries here. It is true honor to acknowledge the presence of our past national president, Dr. Deepak Ogra, our esteemed guest, whose invaluable contribution to pediatrics continue to shape the future of our profession. A special mention must also go to Dr. Dhiren Gupta as well, our special guest, whose present today adds immense value to this event. Apart from this, the presence of Dr. Bakul Parekh sir, Dr. Mahesh Mohte, Dr. Neeli Bhai, Dr. Bharadwaj, is really commendable, and their graceful presence has increased the stature of this CME. I'm equally excited to be the company of Dr. Vinit Bhushan Gupta. He is a chairing this session, a leading name in the pediatric neurology in India, who is serving as a chairperson today. Dr. Gupta's extensive experience and forward-thinking vision undoubtedly enrich this webinar and contribute immensely to our discussions. A sincere salute to senior pediatricians and academicians joining us today from Gwalior, Dr. Arun Ketkar sir, Dr. Ajay Gaur, Dr. Banga sir, Dr. Subhas Dunde sir, Dr. Bellapurkar sir, Dr. Mukul Tiwari, and other contribution in the field who inspire us all. I must also commend the president of Gwalior branch, Dr. Ghanshyam, and Dr. Sir Karunesh as a secretary of Gwalior for their exceptional leadership in organizing this event and bringing together such a dynamic team. Their vision and hard work are what makes this event possible. I look forward to sharing my thoughts and knowledge with you all today, and I am confident that discussion we have here will serve as a stepping stone towards enriching our collective knowledge in pediatric and pediatric knowledge, especially in EG. Once again, my very, very humble salute to everyone present here. Now I am sharing my screen. Is it shared, sir?
Yes.
Is it visible, sir?
Yes.
Okay, thank you, sir. Sir, I'm very happy to share my experience and the interest shown in this topic, e.g. in office practice. We will go with basics and beyond. You can yeah. The whole of the presentation I have formed is some basic knowledge about EEG, what is normal, what is abnormal. We will have some instructive videos also explaining how to fix the montages, what is generalized seizure, what is focalized seizure, according to EEG base and various case scenarios. And we will have a short 15-second, 20-second pleasure break, and we will show a beautiful videos as well. We all know that it was in 1929, Hans Berger, who is known as a father of electroencephalography, he recorded the electric potential between the two electrodes. And since then, there is a development of this important procedure in the field of neurology. The EEG is to the brain what ECG is to the heart. It has been said by Dr. Hans Berger. We all know that cerebral cortex is a 3 millimeter thick layer which contains 6 layers as well, and in that 6 layers lies pyramidal cell, which lies in the third, fourth, and fifth, whereas stellate cell layers four, and we have star pyramidal cell, fusiform cells. And we can see that the EEG wave which is produced is basically the sum of excitatory postsynaptic potential and inhibitory postsynaptic potential, as this is depicted in the this slide. These are the EEG machines. The foremost upper one, what you are seeing here is this is the conventional or analog machine, which was a huge structure initially, and it was run by the stellate, which is filled with ink and all. But as that advancement has taken place, it has been replaced by the digital machines, and the size of the machine has been reduced, but the concept remains the same. These are the technical standard. The electrodes, maybe 21 electrodes, the channel, maybe 18 to 16. Standard montages are usually 5. Sensitivity, average is 7. Filters, maybe a low filter, high filter, like that. Paper speed is usually 30 millimeter per second. Length of the recording, at least 2 minutes for each montage should be recorded. And the total recording time is around 30 minutes, of which 10 minutes should be in the sleep. Activation procedure, maybe 3 minutes, photic stimulation, maybe for 10 seconds each for different frequencies. This is the EEG paper. One EEG paper has a 10-second, one epoch. This is the epoch. It consists of 10 seconds. Each vertical line, it means 1 second. So in a horizontal axis, it is in a time. On vertical axis, it is a voltage. One small segment is around 50 micro voltage. And before any procedure, in pediatrics, we all know that child should sleep. Better is the bigger side, better will be the sleep deprivation age. But in smaller children, it is just not possible. You have to sedate the child, and these are the important drugs. Melatonin is there, trichloral is there, midazolam nasal spray can be used before the EEG as a sedation. Duration of the recording, 20 to 40 minutes. If it is a sleep point, 1 to 2 hours. Ambulatory EEG, 24 to 72 hours. And video recording, this is the gold standard in EEG, but you can see that it has to be recorded about 24 to 72 hours or even longer. So according to American Clinical Neurology Society guidelines, minimum of 20 minutes of technically satisfactory record we should obtain. And this is a placement of electrodes, and it is said to be in the 10-20 international system. And we know that there is a one peripheral line you are seeing. This is made 10% from the ear here, and the mesion and the inion. One longitudinal line you are seeing here is see, this red line has been broken down into 6 parts. Middle one is the 1, 2, 3, 4, 20%, and 2 lateral is the 10%. This is because to have a broader overview so that any area is not missed. That this is sort of a, and we will see the how is marking is been done by the forthcoming video. Just see the here the video. This is this was the basic of how the electrodes are placed and what 10-20 system means. And coming to the montage. Montage means the combination of recording methods meeting the number of channel on a EG. And pattern indicates the montage which takes the predetermined connection forward. We have placed the electrode, but according to the machine, we can change the connections between, for example, like this monopolar. We are showing the ear differential montage. It is connected. All these electrodes are connected to ear differential montage. This is a vertical bipolar. We will see in the next subsequent slide. This is the horizontal bipolar, and this is the crown bipolar. So we have a monopolar recording and we have a bipolar recording. You can see the longitudinal, or it is also known as the double banana method. Here you can see that there is an adjacent electrode are connected in the channel in two longitudinal chain. This is the longitudinal, the double banana. This is the, again, you are seeing the what is video. So this was a longitudinal bipolar montage, as you have just saw in this video. Right median chain, left median chain, right lateral chain, and left lateral chain. This is a transverse bipolar montage. Here you are seeing the adjacent electrodes are connected in a transverse chain. You can see the transverse chain of this bipolar montage. This is a ear differential montage. You can see the A2 as a reference on the right side of the electrodes. Note that input 2 is common for all the channels. This is the same, the referential unipolar montage. This you can see the tracing. The right one is the right hemisphere, like this is the left side, and this is the right side median. So friends, the montage means the montage is the lens through which the brain's story is told. Screen it wisely to uncover the hidden narrative. So you have to watch all the montages according to the situation and grasp it nicely. Activation procedure. We all know that activation is, you can see the hyperventilation, photic stimulation is there, sleep deprivation. We have visual, auditory, and others as well. Sleep-related activations are sleep deprivation. They are all comes in activation procedure, and this is the photic stimulation. It is done by the stroboscope, and they're starting at the frequency of 1 hertz and increasing to 30 hertz or higher, eye open and closed. And this is basically indicated in photosensitive epilepsy or frontal lobe epilepsy if you are thinking of. You can see the photomyoclonic responses, photoconvulsive responses, and we know that there are a few epilepsies which are photoconvulsive or photic stimulation, for example, Dravet and all. Normal responses are series of positive waves are seen over the occipital lid at simultaneous frequency, you can see. So photosensitivity is seen in 5% of the patient with epilepsy, and it is also a feature of progressive myoclonic epilepsy. You can see the patient is exhibiting hyperventilation, and she has already done 3 minutes hyperventilation, and this is a procedure which you can done in your OPD, and later on, having seen that after hyperventilation for 3 minutes, there is a behavioral arrest, you can straight away make the diagnosis of childhood absence epilepsy, and later on you can confirm and write it down when you are sending the patient with for hyperventilation, that you have to do hyperventilation for 3 minutes and to see how these three spike and waves are seen. These are this is a normal hyperventilation. This is after 40, it is beginning. You can see the small waves. As soon as the hyperventilation proceeds, there is a slow waves appearance and then turns to normal after 80 seconds. You can see that activation is the spark that brings the brain hidden rhythm to light. Sometimes it is the key to unlocking what is unseen. So in photic stimulation, or it is a hyperventilation, or it is a sleep deprivation, it is both to make the things overt clinically. These are the drugs which are used if a patient is on phenytoin or in valproic, as you can see, it can cause generalized focal slowing. Valproic acid can cause slowing beta activity. Carbamazepine also alpha activity, reduces the alpha activity. Levetiracetam, like that. All drugs, they will give some or other. You should know accordingly. You have to contribute. This is again a very important. This increases the theta and beta activity and generalized slowing. If sedation has been given by diazepam, it may increase the beta activity or theta activity sometimes, so that it can be difficult to, for example, barbiturate, it can pronouncedly generalize slowing or increases the delta burst. Propofol can cause burst suppression higher. So we should remember at least what drug this patient is taking. So that everybody is aware. Coming to the normal EEG, we know that normal EEG frames, you have to see the frequency of the wave, you have to see the what amplitude which tracing is shown, what is the shape and what is the side. So accordingly, we have alpha, beta, theta, delta, gamma, like that, normal waves, and always correlate age of the patient, and the state of alertness is very, very important. And you can see according to frequency, alpha waves is between 8 to 30 hertz, beta waves is greater than 13, theta waves is between 3.5 to 7.5, and delta waves is 3 or less than 4. So these are and what is background? Background is very, very important. Once you see the EEG report, this is almost all of the background and baseline brain activity recorded in the absence of discrete epileptiform discharges or seizure, and it reflects overall functional state of the brain, but it has influenced by age and sleep wake state and cerebral integrity. And you can see the whole of the background here. So while seeing the background, you have to assess what frequency the waves are showing, what amplitude is there, the symmetry between the two hemispheres is there, their reactivity, whether the child is opening the eye and what is the response, or closing the eye, what is the response on alpha waves, that is important. Then state dependent variation is again responded. If the sleep wave, if the patient is in sleep, it may produce sleep spindles or vertex waves or K complexes, like that. So general observation in the background, you have to assess one by one so that anything is not missed. So how to interpret the background activity? You have to see the reactivity, especially for the alpha waves. Alpha waves attenuated just after the closing of the eye. You should see the posterior dominant rhythm, symmetry and continuity have to be seen. evaluate the amplitude. Is it too low or it is too high? Consider the age appropriateness. And this is the age related normal background. If you are seeing the EG of a neonate, you have to understand what is the normal background. In 3 to 6 months, what is the normal background? And similarly, if you are seeing the EG of 8 years and above, you have to be careful that alpha activities start appearing at the age of 8 years, and it is a posterior dominant rhythm. So this is all important normal age landmark of the EG. Then what is abnormality? If there is a focal slow wave shift there in the tune of theta and the delta activity, you may think of a structural lesion or tumor or stroke or infection. If it is a generalized slow wave, encephalopathy or metabolic infectious post-ictal can be there. If it is an asymmetric one hemisphere or one part of the brain is having asymmetry, so unilateral dysfunction has to be taken. Bus suppression is again a bad prognostic, severe brain injury or coma or Ohtahara syndrome or encephalopathies like that. Disorganized sleep background can also be seen in severe developmental encephalopathies like that. This is the normal awake tracing of a patient. You are seeing the normal posterior dominant rhythm is there, and you can also see this is the in the delta rhythm. High amplitude waves are there. You can see these are the, if you count the frequency, it is around about 3 to 4. This is what is known as the posterior dominant, and is usually seen over the posterior head region. You can see the normal awake tracing of an 8-year-old child in awake state. Note these are the alpha rhythm in occipital. See the P2O2, T2O2. Like these are the alpha waves, and as soon as the eye close, the alpha activity start more. You can see here. This is the eye. As soon as the eye open, the alpha activity is attenuated. It is reduced. As soon as the eye is closed, alpha activity is almost there when during the eye close. So it is an important thing to note in this eye opening, and technician, EEG technician must be told to take eye open and eye closed tracing both. So this is just to refresh. Again, coming to their normal tracing, especially the sleep stages, you can see here, all thing is represented in the slide. When you are awake, as we are listening and attending the CMA, we are all having the beta activity predominant. As soon as we get relaxed and eye closed, alpha activity takes the place. Again, we goes into the NREM phase, theta comes, then the spindle comes, K complex comes, then in stage 3, delta activity appears, and in stage 4, almost slow waves are there. So this starting from the absolutely fast frequency beta waves to delta waves, this is the overall normal sleep pattern you can see. This is the normal. Here, this is the stage N1, what is called. You can see the vertex sharp transient seen over both the central region. This is having the phase reversal as well. And in this stage, this can be converted into K complex in the second stage. You can see the large K complexes as well. This is the K complexes. It is the, you can see the large amplitude delta frequency waves, and symmetric they occur each time the patient is aroused partially from the sleep. So these are all the waves seen in the sleep. These are the K complexes. These are the vertex sharp transients. You can see the phase reversal in the vertex. This is the feature of stage 2 sleep. This is normal sleep tracing. You are seeing stage 2 vertex waves. You can see the sleep spindles are there as if the spindle shaped waves are there with small frequency and enlarging like that. They again coming to slow. These are the repeated wave, vertex wave in deep sleep. These are the sleep spindles. This is again a feature of stage 2 sleep. They are symmetrical and are mostly obvious in the parasagittal region. You can see the 10 hertz frontal here. These are 10 hertz frontal. You can see the frontal leads are there. Again, you can see the stage 2 sleep. These are all sleep spindle. By just seeing, you can say that this is a tracing of during sleep. This is again a normal sleep tracing, but the stage is different. You are seeing the appearance of the slow waves, like in the delta range, and this is known as the N3 sleep. These are all delta wave, delta frequency waves. Making you more fresh, coming to another abnormal EEG, like the background abnormalities. We will see the background abnormalities, and you are seeing this background is having the right-sided leads are very slow, low voltage. You can see where is the left one having the. So this is a low amplitude and featureless side. You can see the child has extensive cystic encephalopathy of the right side. You can see immediately gives you attention that there is a interhemispheric disparity is there. Again, there is a interhemispheric disparity, but it is on the right temporal region. You can see right sided as compared. This was a case of granuloma on the right side. You can see the delta activity here. Again, a burst suppression pattern is there. Severe diffuse brain dysfunction is there. And common causes include severe hypoxic ischemic, and we deal all these cases in the post-nursery patient. HI, metabolic crisis, and general anesthesia can all give rise to burst suppression pattern. And you can see the burst of slow and mixed waves, often high amplitude, alternating with the, you can see the flat, the baseline is also there. Now coming to another abnormal EEG, that is the epileptiform discharges. We have seen the abnormal background. Now we have to pick up the abnormal epileptiform discharges. It may give you a clinical suspicion that this type of abnormality may be there, or which type of condition you can suspect. So these are the abnormal waves. For example, spike. Spike is a straight high amplitude waveform, but its frequency 20 to 70 millisecond. So, and spike and sharp waves is 70 to 200 millisecond. And this is a feature of epileptic activity and focal epilepsy, especially sharp waves. It can be sharp spike and wave. It can be polyspike wave. It can be plates like periodic lateralizing discharge. It can be burst separation, and it can be triphasic wave, for example, in metabolic encephalopathy. So these are the abnormal waves. You and secant, this is a spike, this is a spike, this is a sharp wave, 70 to 200. This is polyspike or spike and wave. These are you can see these are all epileptic form discharges. So let us see in this, you can see the cluster of spike wave discharges you are seeing over the right parietal and right temporal region. And thus localization is the right occipital region, These are the spike discharges. You can see the spike and polyspike waves, you can see associated with myoclonic jets. Myoclonic jets give polyspike discharges. Now coming to the focal epilepsy, just a video of few seconds. So this was the focal epileptic form discharges. You can see this classical discharges from the centrotemporal region. This is a classical example of select epilepsy, that is the self-limiting epilepsy with centrotemporal discharges. This is a very classical. Let us see a small video of generalized epileptic form discharges. You can see here this. Is a So this was a generalized epileptic form discharges. What you are saying is almost generalized epileptic form discharges are there, and it is in sleep. It is also known as SWAS. This is again a generalized epileptic form discharges during hyperventilation, and you are seeing that this is a case of typical childhood absences, 3 spikes and waves. This is again a periodic epileptic form, generalized epileptic form discharges by photic stimulation seen in the child with severe GAB. Chaotic background. We all know that this is a case of infantile spasm or West syndrome. You can see absolutely the background is chaotic. This is this is known as the SSPE, superimposable generalized complex seen in the subacute sclerosing panencephalitis, are time logged to slow jerk in awake state. You are seeing this. This is a plates. You are seeing the left-sided periodic lateralizing epileptic form discharges, a child with stroke involving the left hemisphere. This is the electrical seizure from the right temporal region. You can see the right temporal region. You can see the discharges are coming. Now, this is again very important, and this is a very pertinent question in everybody's mind, that why in epilepsy sometimes EEG is normal. We are thinking that discharge should come. So let us, we will discuss it later on also, but see the video and some basic concept regarding this.
Anoop sir, when you run video, sound doesn't come. If the sound is not there, or you have to share computer
Sir,
sound.
sound नहीं आ रहा सर.
सर वो आप ना, आपको सेटिंग में जाके शेयर कंप्यूटर साउंड होना करेगा, तब आएगी. आप ऊपर जाओ, ऊपर वो जो वो होता है ना, फ्लोटर्स होते हैं, फ्लोटर्स में आप राइट को क्लिक करोगे तो उसमें लिखा हुआ आएगा शेयर कंप्यूटर साउंड. मुझे लगा आप म्यूट हो रहे थे, मेरे को लगा शायद वीडियो में साउंड होगा.
नहीं, वीडियो में तो साउंड है सर, पूरा
आप
साउंड
उसको
है.
सर, वो जूम पे फ्लोटर आते हैं ना, फ्लोटर पे 3 डॉट्स बनी हुई है, उसको क्लिक करोगे तो उसमें लिखा हुआ आएगा. जूम की सेटिंग पे जाओ सर, जूम की सेटिंग पे जाओ. नहीं, आपकी जो प्रेजेंटेशन है ना, ऊपर जूम की सेटिंग अपने आप आ रही होती है, उसमें जाओ आप. उसके राइट साइड में शेयर कंप्यूटर साउंड. आप वो अपनी विंडो को ऑफ मत करो सर, जो विंडो आपकी चल रही है ना, आपकी विंडो जो चल रही है, इसी में आप करोगे, ऊपर आपकी जूम की सेटिंग आएगी, आती है ना वो फ्लोट करते हुए. वो कहाँ है आपकी वो जूम की? एस्केप करोगे तो शायद आएगी.
रिकॉर्ड ट्रांसलेटर.
इसको मिनिमाइज करो सर प्रेजेंटेशन को, और लेफ्ट साइड में कभी जूम पे होगा वो नीचे.
शो मीटिंग साइट कंट्रोल.
नहीं सर, इसमें जब जूम खुलता है तो ऊपर फ्लोटर आता है, पूरा लिखा हुआ कितने लोग एंटर कर गए हैं, जिसमें लोग भी बने होते हैं, कितने लोग हैं, राइट. उसमें आता है सर.
ये जो तीन डॉट्स आ रहे हैं अलग,
पार्टिसिपेंट्स लिखा है ना सर वो.
हाँ,
ये इसमें
वो उसके वहां पे लिखा आता है. ये शेयर अगर आपकी ओर नहीं है तो छोड़ दो, आप बाद में देख लेना, वैसे बता रहा हूँ मैं.
नहीं, बट इट इज वेरी गुड सर, वीडियोस आर वेरी गुड.
हाँ, तो मैं वही कह रहा हूँ ना, वीडियो सेल्फ एक्सप्लेनेटरी, वो एक्सप्लेनेशन नहीं आ रही है, एरो तो घूम रहा है लेकिन आ नहीं रही है. तो आपको
ये कंट्रोल्स में
कंट्रोल्स में
ये
राइट क्लिक करोगे,
वॉल्यूम के लिए
शेयर ऑडियो आएगा, कंप्यूटर ऑडियो, तभी आपका आएगा उसमें।
कंट्रोल्स
इसमें राइट साइड में कंट्रोल्स आ रहा है ना, उसमें वॉल्यूम दिखा रहा है।
हाँ हाँ हाँ, वहीं पे आएगा सर।
ऊपर ऊपर कर्सर लाइए, ये कंट्रोल्स नंबर 2 सेकेंड
अच्छा,
विंडो
साइड
नीचे और
स्लाइड कंट्रोल,
इसके नीचे आइए, इसके भी नीचे।
स्लाइड कंट्रोल कैसा ये?
नहीं, इसके ये कर्सर नीचे लाइए, ये कंट्रोल्स, ये वॉल्यूम आ रहा था इसमें कंट्रोल्स ये।
नहीं, वॉल्यूम तो फुल है सर वो उसमें।
अच्छा,
मीटिंग
ये
सर वो
वॉल्यूम फुल है ना सर।
जूम पे आई थिंक आप एप्पल से कर रहे हो शायद।
हाँ जी सर, हाँ जी सर।
एप्पल का मेरे को भी आइडिया नहीं है, लेकिन जब भी जूम पे हम करते हैं तो एक काम करो, आप मेरे को जरा एक बार वो बनाना, मैं अपनी स्लाइड शेयर करके आपको बताता हूँ कैसे कहाँ पे आएगा
स्विच टू
कंट्रोल।
फोन ऑडियो, इसमें सेलेक्ट है माइक्रोफोन लिखा है, सेम एज ए सिस्टम मैक लीव कंप्यूटर ऑडियो पार्टिसिपेंट।
एक मिनट सर रुकना।
ये धीरेन जो बेसिक होस्ट है उसके कंप्यूटर की सेटिंग में कुछ होगा क्या?
नहीं 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 सर, जो भी शेयर कर रहा होता है प्रेजेंटेशन, और उसके उसमें आपका लिखा हुआ आएगा, जो फ्लोटर्स होते हैं ना, उसमें एक आता है कि हाइड फ्लोटर्स। हाइड फ्लोटर्स के नीचे और आओगे तो वहां लिखा हुआ आता है कि वांट टू शेयर द ऑडियो, कंप्यूटर ऑडियो, तो उसमें आता
अच्छा,
है ये। इसमें पता नहीं कहाँ है आपका, दिख ही नहीं रहा।
फेस टाइम
ये
मल्टी कैमरा,
ये है एनिमेटेड, फॉर्मेट, अरेंज, वॉल्यूम, एडिट, मूवी स्टार। ये आपके वो कहाँ है सर, कंट्रोलर्स कहाँ है?
गूगल चाचा से पूछ लो ना कि मैक में कैसे करते हैं।
एक मिनट।
मतलब अरे इतना अच्छे अच्छे वो वीडियो, मतलब आवाज आई नहीं क्या?
हाँ हाँ सर, हमें लग रहा कि आप चुप हो गए हो या कुछ तो गड़बड़ है, मेरे को आई कुड सेंस कुछ तो
ओहो,
गड़बड़ है।
ओहो।
रुको, हाउ टू शेयर।
नहीं, हमें वास्तव में लग रहा था कि वैसे ही इतने अच्छे हैं तो हमें लगा कि
नहीं
साउंड
नहीं,
नहीं है
किसी
इनमें।
और को ये प्रेजेंटेशन दे दें, वो शेयर कर दे।
नहीं ठीक है, वो तो खत्म ही करीब करीब हो गया सर, वो कोई दिक्कत नहीं है।
हाँ, पर वो
अच्छा,
आगे भी जरूरत है तो धीरेन को दे दो, होस्ट बना दो तो वो कर देगा ना।
एक मिनट सर। अच्छा, वो जो वीडियोस जो अपन डाले हैं वो बच्चों वाले, वो भी सुनाई नहीं दिए क्या?
नहीं, कुछ भी नहीं सुनाई दी।
ऑडियो वीडियो में शायद है ना, वीडियो सेटिंग में
ये
कहाँ है
ऊपर
क्या?
प्ले वाले में तो नहीं है, ऊपर जो देखा
वीडियो
प्ले वाला
सेटिंग
क्लिक।
ओरिजिनल स्टॉप स्टूडियो ऑलवेज डिस्प्ले फेस कैमरा ऑडियो।
सर ये है स्टार्ट इज जूम मीटिंग, ठीक है, आपने करी जूम मीटिंग, क्लिक शेयर स्क्रीन, वो आपने करा, एंड
जी,
सिलेक्ट शेयर साउंड। इन द शेयर विंडो यू विल सी द ऑप्शन ऑफ शेयर कंप्यूटर साउंड, क्लिक दिस बॉक्स।
शेयर कंप्यूटर शेयर एप्लीकेशन, शेयर इंडिविजुअली ऑल विंडोज फॉर एप्लीकेशन ऑटोमेटिकली सेट ऑल। शेयरिंग स्क्रीन में आएगा ना सर? नहीं।
नहीं सर, एक बार
ये
आप पहले स्क्रीन बंद करो अपनी,
अच्छा,
आप अनशेयर करो और फिर से शेयर करना शुरू करो, फिर आप
स्टॉप
देखो।
स्टॉप करें सर?
हाँ, शेयरिंग स्टॉप करो, वापिस जाओ, आप शेयर करो। एक मिनट।
अच्छा, ये स्टॉप शेयरिंग हुआ, उसके बाद फिर से
अब देखो सर, अब नीचे, एक मिनट, अभी आप ना नीचे, आप वो आ रहा है ना, एक बोर्ड आ रहा है, अभी एक मिनट, एक सेकेंड, मीटिंग सेटिंग्स।
ये तो फिर से शेयर हो गया, अब तो स्टॉप करूँ क्या इसको?
एक इसमें कहीं ना कहीं आएगा। ऊपर के सर वो है ना, वो करना आप ये एक तो जूम वर्क
इसी
प्लेस
में
है,
मिलेगा,
मीटिंग है।
शेयर को क्लिक करिए। अनूप भाई जो शेयर है इसको ही क्लिक करिए, इधर जो आपने पहले
शेयर
कर्सर
से
रखा है।
ये इसमें ऑप्टिमाइज ये ऑप्शन है शेयर साउंड करके, ये अब आएगा सर, अब आएगा। चलो एक मिनट देखते हैं, अभी एक बार देखना है सर। आ रहा है सर?
नहीं आ रहा सर।
नो,
आ रहा है सर आवाज?
नहीं
नहीं।
अभी नहीं आ रहा।
नहीं अभी तो प्ले नहीं किया ना आपने।
सर ये मीडिया में जाना, मीडिया में, हाँ ये मीडिया को करना, हाँ इसको करना जरा। नहीं नहीं सर, उसी में मीडिया, शेप के बगल में मीडिया जो है।
हाँ अरे बहुत दिन से मैं सोची थी निकालूंगी, फैंसी उन्हें फालतू की, ये तुम अपने लो।
सर वो राइट साइड में आप।
कंट्रोल, स्लाइड कंट्रोल में।
सर ये आपके जूम के जो कंट्रोल्स है ना, ये आपके लैपटॉप के कंट्रोल्स हैं। लैपटॉप के कंट्रोल्स में नहीं हमने जाना है, जूम के कंट्रोल्स आता है ना एक, ये क्या कहते हैं, फ्लोटर आता है।
ऐसे ही है पता नहीं।
जब आप टच करोगे ना, एक फ्लोटर आता है नीचे,
जी जी एक मिनट।
और इसमें आपके फ्लोटर पे आएगा। एक मिनट सर, मैं करके देखूं जरा, शायद मैंने भी वो है ये मेरा आईपैड है शायद, इसमें रुको मैं देखता हूँ, एक मिनट मेरे को मालूम पड़ जाएगा। स्क्रीन, जस्ट ए मिनट। सर ये देखो, आपने जैसे ही मैंने किया ना, शेयर डिवाइस ऑडियो, वो मेरा
अच्छा
इमीडिएटली दिख गया। एंड
ओके।
ऑप्टिमाइज फॉर वीडियो,
ठीक ठीक।
इमीडिएटली जैसे ही मैं करता हूँ तब आ जाता है डिवाइस ऑडियो, राइट। तो आपका
अभी
जैसे ही आप शेयरिंग स्टार्ट करते हो,
जी,
तो यू आर
शेयर डिवाइस
शेयरिंग
ऑडियो,
स्क्रीन, और सबसे पहले लिखा हुआ होता है शेयर डिवाइस
शेयर
ऑडियो, वो
डिवाइस,
आपको
ठीक है
करना
ठीक।
पड़ेगा। अब
ठीक
करो
ठीक
आप।
अभी करता हूँ।
इससे बोल रहा हूँ आगे के लिए काम आ जाएगा। ग्वालियर में तो हमारे घर की बात लगती है ना, इंटरप्ट करने में आपको लगता नहीं कि अजीब सा।
स्क्रीन जो
आपको
है,
आपको फिर से वो करना पड़ेगा।
नहीं अभी मैंने किया उसको, बाहर जा करके किया, स्क्रीन शेयर नहीं हो रहा है।
अब ये फिर से बंद करके ना, वहां पे जो क्लिक दिया है ना बंसल सर ने, उसको क्लिक करोगे तब खुलेगा वो। तब उसमें शेयरिंग के बाद आएगा, जैसे आपको होस्ट ने राइट दिए हुए हैं ना आपको कि शेयरिंग
जी
स्क्रीन, जैसे ही आप शेयरिंग स्क्रीन लिखोगे तो उसमें एक डॉट आ जाएगा, डू यू वांट टू शेयर द कंप्यूटर ऑडियो। अगर नहीं बची है वीडियो तो छोड़ दो, बाद में प्रैक्टिस कर लेना।
अभी वो तो ही हैज लेफ्ट द जूम ना। हाँ अभी जाए ना।
अब आप शेयर करो सर अपनी प्रेजेंटेशन, चलाना जरा। सर वो आपकी ना स्क्रीन शेयरिंग के टाइम पूछता है, डू यू वांट टू शेयर ऑडियो। आप इसको शेयरिंग बंद करो सर सबसे पहले।
जैसे ही मैं चालू करता हूँ तो फिर वो अपने आप डायरेक्ट ही आ जाता है।
हाँ, एक बार
ये
करना
जैसे,
जरा।
ये देखिए मैंने किया, यू आर शेयरिंग द स्क्रीन, और participation, and now you are seeing your screen.
तो आपको वो आ रहा होगा ना सर, एक फ्लोटर आ रहा होगा जो जूम का फ्लोटर है। ये सारे ना आपके कंप्यूटर के कंट्रोल्स हैं जो आप हमें दिखा रहे हो। हमें आपको जूम के कंट्रोल आपको ही दिखेंगे, हमें नहीं दिखेंगे आपके। जो एक फ्लोटर नहीं घूम रहा होता, टच करो स्क्रीन तो नीचे आ जाता है, जैसे मेरे पास आ गया नीचे, जैसे
ये है
टच
ना सर,
करोगे।
जी जी
हाँ,
जी,
पार्टिसिपेंट्स एंड ये देखो मैं टच करूंगा तो नीचे आ रहा है।
चैट, हाँ,
हाँ, चैट वाले में तो रिकॉर्ड कैप्शन उसके राइट में जाते रहोगे ना तो मोर आ जाएगा, मोर में आएगा वो।
अच्छा, मोर में है ना, मोर में रिकॉर्ड हो गया, ट्रांजिट हो गया, डिसेबल एनोटेशन फॉर अदर्स,
हाँ, और
हाइड
उसी में
नेम्स,
आएगा, उसी में
हाइड
आएगा।
वीडियो पैनल, हाइड फ्लोटिंग मीटिंग कंट्रोल।
हाँ, उसमें आएगा शेयर।
हाँ, शेयर कंप्यूटर साउंड है ना।
यस, ये है
ये
सर।
आ गया। स्टीरियो मोनो में डालूं कि स्टीरियो में डालूं?
सर कुछ भी डाल दो, काम तो हमारे दो हैं, सुन लेंगे।
इसमें लिखा है
ओके करो सर,
to
ओके।
share your
पासवर्ड,
computer audio, please install the Zoom audio device. Please
हाँ ये कर दो ना आप, पासवर्ड डाल दो, अपने आप ले लेगा सर। वो आपने डाला नहीं था, पहले भी आपने किया था। ये एप्पल है ना सर, ये थोड़ी सी सिक्योरिटी फीचर्स होते हैं इसके अंदर, उसको लगा के कहीं आपकी कुछ और ना साउंड चली जाए पेशेंट्स की। क्या हो गया सर, पासवर्ड भूल गए? सर ज्यादा करोगे वो ब्लॉक कर देगा। हाँ, अब वो शेयर करो ऑडियो साउंड।
Some patients with epilepsy might
यस,
not
अब
have
ठीक है सर, अब
epileptiform
ठीक है।
discharges. We can consider a couple of things.
ओहो, तो विवेक, कहाँ चले गए? जी हाँ सर, अब ये
Some
so we were somewhere here. Electrical seizure from right temporal region, and this is so many times the situation comes when in epilepsy sometimes EEG is normal, we are expecting to receive some information from EEG, but unfortunately we are not. So what could be the reason? There may be more. So let us see this
Some
video.
patients with epilepsy might not have epileptiform discharges. We can consider a couple of things. Here I have shown a coronal section of a brain. I have placed the approximate position of the standard EEG electrodes on this image. The two major determinants of seeing a scalp abnormality are the area of cortex involved and the location. For example, I have shown here a star which represents a small area of cortex that has synchronous abnormal electrical activity. Because this area is small, it might not be picked up by the overlying electrodes. If a larger area is involved, such as shown here, it might be more likely that this abnormality would be picked up by scalp electrodes. In general, 10 to 20 square centimeters of cortex has to be involved in order for the abnormality to be consistently demonstrated on scalp EEG. The other main determinant of a scalp abnormality on EEG is the location of the synchronous cortical activity. In this example, I have shown a very superficial area of cortex involved, which might be more likely to be picked up by scalp EEG electrodes. If a deeper area of cortex was involved, such as in the cingulate gyrus, shown here, in the mesial temporal structure, shown here, or in the insular cortex, shown here, it may be less likely that such abnormalities would be picked up by the more distant scalp electrodes.
So this was to make you alert. And again, artifacts are the waves or groups of waves which are produced by technical or other disturbances which are not due to brain activity. It could be due to machinery, It could be due to voltage. So the artifacts are the waves which are not contributed by the cerebral hemisphere or the brain. It could be from muscle artifact, it could be somewhere else. So let us see, these are the artifacts like eye blink. If the patient blinks the eye during the tracing, it can have an artifact. Lateral eye movement can have a muscle artifact, khas diya, artifact aa jaye. Movement artifact, ECG artifact, electrode pops, sweat artifacts. So these are the artifacts and these are the sources and these are how they are having an EEG appearance. For example, in this slide, you are seeing a fast beta sort of activity is there, but it is here is the importance to note the artifact. It is very important for technician, EEG technician to report as, for example, in our analog machines, you can immediately make the mark. Yes, yes, this was a cough, this was a moment artifact, like that patient has moved the arm, you can write it out. But in digital, we cannot. But definitely, you can make it point that during this montage, there was a like. So this is a muscle artifact is there. This is again a moving the head box artifacts is there. Again, you can see the child coughing, and if the EEG technician has not written that it was, you can immediately shift to polyspec discharges or something periodic discharges like that. So this is very, very important. EEG technician is a very important person regarding taking the during the tracing. These are the eye blink artifact. You can see there is a over the frontal lids are there. This is the ECG artifact. Here the ECG tracing, and these discharges are corresponding to the beats which are in the ECG. This is the muscle artifacts, very, very fast activities. This is the sweat artifact. This is. So going again, now we are shifting to case scenarios. Here is a case. He is having a seizure. 11-month-old child with a brief generalized seizure on the day one. He is playful and has no focal deficit, has a normal development. There is no family history of seizure disorder. And what is your diagnosis? So definitely, you can see the EEG was done on parent request and depicted few discharges. Again, on the base of EEG, valparin was started. So what will be your comment? So looking to the overall picture, this appears that this patient having a simple febrile seizure. EEG in fact was not required, but was done. So there is no febrile seizure specific EEG finding. Even if you require or advise EEG during febrile seizure, it should be a recurrent sort of febrile seizure or development of afebrile seizure in between febrile attacks, or it is the onset of epilepsy within following 2 years. If this may be the indication of ordering EEG in febrile seizure, normally we should not advise a simple febrile seizure to have EEG done. So friends, in the rush to treat something, we forget that the simplest answer is often the best. Not every febrile seizure needs a complex approach. Now the indication, you can see the prolonged or complex febrile seizure, recurrent febrile seizure with underlying developmental delay or neurodeficit is there. Such type of situation, if the patient is having a seizure, then you can advise for EEG. Another patient, just see the video. 3 years presented with 2 episodes of abnormal movement. You can see there was a history of provocation was there, both episode, no history of epilepsy. Would you like to do EEG in this case? However, EEG was done and showed the discharge. What is your opinion? This semiology, the patient is exhibiting is classical of breath holding spell. Though he is exhibiting a tonic sort of seizure, but there was a provocation, there was a breath holding spell. So 10% children without epilepsy will have abnormalities on EEG, but it does not mean that you have to start anti-epileptic drugs. And this is the diagnosis. Reflex anoxic seizure is there and treat the condition and not EEG, even if it shows the minor changes. So this is a very important. So history is the plinth in building the diagnosis. So in the pursuit of answers, sometimes we chase the shadow instead of light. Not every spell calls for a diagnosis, and not every diagnosis needs a treatment. That is very, very important. So again, a clinical situation. A 4-year-old child with history of afebrile seizure 4 times in the last 6 months. It was a semiology of GTCS. All were unprovoked seizure. Routine investigation was normal. EG was advised after 1 month, was reported normal. So do we consider him as epilepsy? Is it an epilepsy? What is your take in this situation? Now the scenario is that patient having a classical seizure, afebrile seizure, but EEG was normal. So let us see. EEG, epilepsy, is a clinical diagnosis. So therefore, what ILE has said that at least 2 unprovoked seizure occurring greater than 24 hours apart, and 1 unprovoked seizure with a recurrence risk of 2 unprovoked seizure occurring over the next 10 years. This was the case of Sturge-Weber. So these are the cases which immediately, even after the first attack, you have to start the seizure. And there is a third group where there is a signature EEG. You see the EEG and you can diagnose. So as if such person comes, you have to label it as epilepsy and deal accordingly. Now, what is the optimal time for EEG after a seizure? This is again a question. So it has been seen that if EEG is done within 24 to 48 hours, it gives a maximum yield. And if it is less than for 24 hours, it may give information, but there is a post-ictal slowing and disturbances are more. So definitely the researchers and the other things have been shown that high yield is between 24 to 48 hours. So you can see the if EG is performed too early, that is less than 6 years, so आया झटका आया तुरंत EG करा, that is the post-ictal slowing or diffuse attenuation may dominate. Repeat it after 24 to 40 or 48 hours if it is a non-diagnostic. So the best time to perform EG is within 24 to 48 hours. So friends, timing is the art of clarity, and EEG performed at the right moment tells the truth, but the haste may lead to confusion. So the yield of EEG is almost only 30 to 55%. It is not 100%. All epilepsy will not give, the yield is 30 to 55%, that we have to understand. All normal EEG report cannot rule out epilepsy. Then again, an important thing. Yield of EEG improves within the first 24 to 48 hours. So this is again an important point. A normal EEG may reflect the calm, but it does not always tell the whole story. Epilepsy may still be hiding in the shadows. Another patient. He is an 8-year-old girl with a history of episode in sleep, seizure episode in sleep. Gets seizure within the first hour. Facial deviation is the grunt-like sound is the clonic movement of the limb. Had 2 episodes in the last 8 months. Awake record was done and it was normal. You can see this is the patient whose semiology, whose history is classically directing you in a particular epileptic syndrome. But then the EG which was done by a pediatrician or by a referral doctor who never asked for a sleep EG or like that. So awake EG was normal. Now, this is the normal awake tracing of the same patient. Now here this, after sleep, you can see the EEG has revealed the presence of spike discharges, which is very classical bipolar discharges from the centrotemporal area. So the diagnosis is select. So in the silence of sleep, the brain speaks louder. What's hidden in the wake can reveal itself when the child rests. This is again an important clue. Another patient you are seeing, the same page of the same. This is in fact a seizure video taken at the home only of a select patient. You can see the facial grunting, focal seizure, frothing, drooling of the saliva persist, and this is you can see the discharges. This is again a temporal unilateral discharges was there. The bilateral can be. This is a very classical sort of discharge in the central temporal region, which can be unilateral, which can be bilateral as well, but a normal background is important. Another patient, see the video. 10-year-old, frequent blanks, history of poor scholastic performance, possibility of absence was considered, and the patient recorded awake record and without hyperventilation. So again, the EG was absolutely normal. So a referring pediatrician should write what he is thinking of regarding this situation and what he wants to advise regarding the hyperventilation or fatigue stimulation or sleep deprivation. It has to be adequately documented in the referral letter. Now you can see the hyperventilation was done, and you can see the 3 spikes and wave, and you can see clinically as well. He is having the behavioral arrest. So this is a classical childhood absence epilepsy. Another patient of during EEG, when EEG is performed, you can see the discharges is coming. And the mother was responding. She is not responding to the mother's command as well. You can see the 3 spikes and waves. So you can use your mobile camera. I was standing by the side of the patient and taking video of this patient by this. So it can be good as a. Again, we can see a patient with behavioral arrest and neurodevelopment normal, frequent. You can see these in these spells, and you can see again hyperventilation, and MRI was absolutely normal. And this was in fact a patient of daydreaming, and presence of psychological stressor was there. His frequent stare was there. EG was normal. No posterior confusion and tiredness was there in this patient. So family history, eyewitness account of semiology helped. Now, this is again a very interesting case. The diagnosis is written on the spasm. Diagnosis is almost clear what you are saying, but you have to clarify, you have to document that yes, what we are thinking clinically should come up in the EEG. This is a 7-month-old patient, neonatal hypoglycemia, seizure, developmental delay, note the abnormal movement jerks, usually in the early morning. As soon as the child wakes, there is a spasm, more concentrated during the wake cycle, and definitely you can see the chaotic background of this condition. High voltage, irregular, asynchronous, slow waves are there, and sharp waves, spikes, polyspikes are feature of hips arrhythmia pattern. Another patient you are seeing, see the spasm. This is a seizure begins before 3 months. Tonic spasm is there. Focal partial seizure was there. And EEG is the most important to diagnose this OTA. You can see the spike discharges coming very frequently. Burst suppression is there. Again, this is another situation. You can see early morning, female patient, jerks are there. Both the upper limbs are involved, and he used to drop, not responding to anti-epileptic drug, come with such type of history. And you can see the discharges that are coming in this polyspike discharges are there. This is photoparoxysmal responses seen in the IgE. This was a case of JME, and you can see the polyspike discharge. Another patient had a focal seizure after first DPT injection, recurrent focal seizure, myoclonic jerks, static milestones, birth history normal, family history of febrile and afebrile seizure was there. So first seizure was clonic with fever since the age of first year. Second seizure was myoclonic. Third seizure was absence at 5 years. Photosensitivity is also. So diagnosis is almost clear that we are dealing with Dravet syndrome, which have a very peculiar sort of presentation. And this is you can see we know that SCNA1 mutation, SCNA1B mutation can be there. And this is the EEG. This is the conventional analog machine tracing. You can see the long the pens are vibrating and giving the response. 4 to 5 polyspike waves is seen, and photosensitivity is an important feature in Dravet syndrome. Another patient, 8-year-old, with history of sudden fall. This is the atonic sort of myoclonic jerks, GTCS, atypical and tonic seizure in this seizure. And you can see the EEG tracing in this. You can see the multiple seizure types over time. The atonic myoclonic seizures are there. and slow generalized 1 to 2.5 hertz, that is the slow spike, and slow waves are also seen. Activity enhanced in any NREM phase, and spikes have frontal predominance. So this is a case of LGS. So it can be a slow spike wave paroxysm or it is a non-convulsive status. So another patient who is in front of you is a normal preschool children, severe nocturnal vomiting followed by eye deviation and status epilepticus. Excellent is outcome is excellent. So this is a classical case of Panatopolar syndrome, benign childhood epilepsy, occipital paroxysm, and the drug of choice is carbamazepine. You can see this is the paroxysmal spike. Paroxysmals are coming from the occipital areas. Bilateral, synchronous, independent spike focus are seen over the occipital area with normal background. This is the benign childhood epilepsy. This is again a 2-year female patient. You can see the record absolutely full of seizure. EEG done after child brought to the hospital. Large amplitude discharges was there. Another patient. He was treated by a pediatrician just by history only. Father said that he is having a lot of abnormal movement, sort of mirgi, and he was already on the Levipil. Started when he came in my OPD and he started doing this activity. Do you think that this is favoring such any type of seizure? So we will see that eyewitness account is very important. Eyewitness account is very important. Explore the possibilities. See, this is having seizure. The child is exhibiting seizure on command. Yes, now you start the seizure, he will start. Now see the precipitation or request. Now see the second video.
चल चल हो गया बंद कर दे है ना घर जाएगा कि रुकेगा
See, so cessation on request. So this is the important condition of non-epileptic condition. So I just by history you can stop the there is no need of EEG, but in fact we have done EEG in this patient. A lot of artifacts was there in the same patient. Another patient who presented with a history that a sudden loss was there, twitching was there, and the patient was exhibiting seizure activity. But in fact, the eye blinking is an important clinical marker that gives you a clue that is not a seizure activity, but a non-epileptic condition. So EEG was normal. It was already done before it is coming. So eyewitness account and EEG helps to differentiate non-epileptic events. And this is again a video is about the 1,000 picture. This is all non-epileptic event. Do you think any investigation is required? If you have not seen this patient earlier and the patient was saying that female child exhibiting abnormal jerks and all, actually most of the time general practitioner will start anti-seizure medication. So this is a very important area. Do you need an EEG? No, definitely not. So friend, it is time to stop now. Hope this we would take home says epilepsy is a clinical diagnosis. EEG is not a confirmatory test. Make a tentative clinical diagnosis. Mind your mind before sending the EEG. Before EEG, video EEG is a very important and gold standard. Or always remember that the video EEG is to be taken for at least 24 hours. So where you are doing video EEG, you must have all sort of facility to abort the seizure or to resuscitation facility. The technician should be adequately trained for managing all these, and that only this is only possible in a dedicated neurology clinic and corporate hospitals as well. So your treatment should be driven by the clinical and supportive investigation and never alone by EEG. So it was all from the basic and beyond. I'm sorry that the earlier videos and earlier presentation was not listened by you. So sorry for that. And this was all from my side. And
We will definitely get you to speak again with us. No issues.
Thank you very much,
So
Anoop.
there is,
It was a very interesting presentation. We have learned a lot because not able to read EEG is like learning disability among doctors. And we have learned many things about EEG, and we have learned how to use the Zoom from Dhiren. So this was a bonus in this presentation. Your quotes were very interesting, and if you compile the quotes, that again will be a book. Thank you very much for explaining all these things to us. And still, we have some of the questions. You already answered many, but still we have some of the questions. So I request Dr. Anand Ketkar first with his 2 or 3 questions.
Thank you. Most of the things are clear, but one question remains. How can we see the improvement in EEG, whether it is conclusive, or would it give some guidance to us to stop anti-epileptic drugs, or what we'll find in recovering EEGs?
Sir, actually, EG is a very important summary sign of improvement in EG. Normalization, there are certain criteria by which we can think that after taking the treatment, after aborting the drug, after 2 years of seizure-free interval, if the EEG shows that there is a normalization of the baseline rhythm, especially return of the alpha in wakeful, or reduction of disappearance or reduction or the disappearance of the spikes which was previously there, sharp wave which was previously there, epileptiform activity which was previously there, now it has been disappeared or reduced in number. Absence of post-ictal suppression, that is the decreased frequency or resolution of the seizure in the EEG pattern. Improvement in the sleep architecture, and the return to normal sleep pattern can be there. Improved brain responses to external stimuli like that photic stimulation and hyperventilation has now come to very normal. Improvement in the seizure control, clinically and electrophysiologically. So this is very important. So whenever we think of seeing a patient after treating it and considering that he is improved to EEG as well as clinically. Clinical improvement is very important. So EEG improvement should be correlated clinically as well.
Suppose if after 2 years he doesn't have any seizure for last 2 years, and but EEG pattern, it shows some differences. So should we continue the treatment?
No, sir. Stopping the anti-epileptic drug, it is good for it. It has been shown that 2 years seizure-free interval should be there to start thinking of tapering the anti-epileptic drug. Even if it is there are minute discharges or discharges, it does not mean that you have to further continue. If you are satisfied clinically or the patient is had no seizure free, so we can stop the anti-epileptic drug. What Dr. Vineet would
Yes, sir.
suggest?
I would first of all, very many congratulations. You've covered so extensively in such a simple terms that it is amazing. I'm really again impressed the way you have put your slides and in order. I'll elaborate a little bit later, but coming to your question, Dr. Ketka, the 2 year is the criteria is not anything which has been vetted, which has been tried, double blind tried. It is basically based on the large cohort of clinical experience of the pupil. That the first thing you have to consider why the anti-epileptic was started, the root cause, because not every epilepsy will be get controlled in 2 years. Like Dr. Verma has already shown, a child who has a Dravet syndrome is never going to have in 2 years' time. or a child with a West syndrome or a Lennox-Gastaut syndrome. So what he is talking about 2 years is probably we are talking about a simple select, like or a childhood absence epilepsy, the simple basic thing that you're talking about. Then yes, 2 years is fine. And internationally, EEG repetition is not recommended. Having said that, because of the poor compliance, because of the poor understanding of our patients, it is sometimes imperative that we should repeat an EEG before closing the treatment, but it is not a recommendation from international forum. So 2 year is a very simple terms, it is said, but nothing to do with a kind of it is a hard fact that you have to stop after 2 years. No, there are many patients who will have. There are criteria that when to stop, how to stop. Everything is there. There is the whole book on that. But never ever think that every patient will get stopped after 2 years. That's my only substance.
Okay.
Thank you.
Thank you. Thank you, sir. Secondly, these spike waves, they can be in alpha, beta, or gamma, or they will be only just spikes you name as spike waves. They are unrelated with their amplitude or with their voltage fluctuation.
Yes, sir.
What I mean is these spike waves, which are abnormal waves, so do you classify them in alpha or beta or gamma, or they are just named as spike waves?
No, these are sir. We have a normal rhythm. We have abnormal rhythm in the form of disturbance on the background or epileptic discharges. Spike wave, polyspike wave, burst suppression. They are all epileptic form discharges. For example, if there is a delta activity is there, it can be epileptic form, especially when it is a focal one. So in such type of spike discharge is there, spike wave is there, burst suppression there. We don't count spike in the. It can be solitary spike, it can be poly spike like that, but we does not measure it as in the beta wave or alpha wave.
Okay.
I think Dr. Vinit will.
Sir, no, you have covered it. Just to a little bit more specific on that, the alpha, beta, delta, they are the basic rhythms, as Dr. Anoop has already detailed in the very beginning, very early slides. What you are talking about, sir, about the spike or spike wave, they are not normal. They are not classified in alpha, beta, they doesn't fit anywhere. They are the separate entity and they stand out beyond the background. These basic rhythms are background rhythm. But these abnormalities are the standing out of the abnormality. So no, there is nothing like in the spike, alpha spike or beta spike name. What you said, yes, if you get a focal delta, yes, if there is a slowing, there is a structural defect underlying, then you will get the focal delta spike. But that's a different thing. Or a delta brush, which we occasionally see in NMDA and encephalitis. That's a completely different thing. So in your question, regarding your question, the spikes or a spike wave are not classified as a alpha, beta, or delta anything. They are a standalone entity.
Thank you. Thank you, sir. Back to Banga.
Now, Dr. Suhas, do you have any questions to ask? Dr. Suhas? So by the time he joins...
no, I'm here.
Suhas is already there. He has to unmute himself. Unmute it, please.
I did. What is there is one question that was asked as to what, if midazolam is given as a sedation, what it will do to the EEG?
What sedation?
Midazolam.
Midazolam in fact is used as a sedative before EEG. For example, pedichloride, it does not changes much the background and all, but definitely these are the 2-3 drugs which are used before EEG. For example, pedichloride, midazolam spray. Even these are all. I don't know ki they are having some effect on EEG tracing because we use commonly these drugs.
Okay.
Well, the melatonin and pedicloral, the trichophorid doesn't
Yeah.
have any impact on the abnormality or background. If you give midazolam IV, then certainly it will have impact. If you are using midazolam nasal spray,
Nasal.
if you are using nasal spray,
Nasal.
then the dose is not enough to significantly suppress the background activity or abnormalities, because you're not using the treating dose, you're all using the sedating dose. So it's not usually not the scenario.
Okay. Thank you, sir. Thank you very much, Dr. Banga.
So that means the very low doses of the midazolam do not have any effect on the EG.
Yes, sir.
Well, you are doing if you have to give midazolam nasal spray in a child for the sedation, the dose is very small.
Yeah.
So it is unlikely it will have, but we prefer not to give it, and in most of the situations. But if you are desperate to do the EEG on that day, then you can use it. And because if you're desperate, that means you are suspecting a lot of abnormalities there. So if you are doing a routine EEG, then I would suggest not to use midazolam spray. Send the child back home, and next day you call them that okay, just don't the sleep deprived, so that you use your triclophos and he will sleep, because he's sleep deprived. He want to sleep and he use the medicine.
Okay.
Thank you, sir. Anoop bhai, we send the patient for EEG and we do not know which machine that person is using. Maybe older machines, the newer machines are more sensitive to the means EEG changes. So we do not know which machine that person is having. Does it matter?
Yeah, definitely, sir. Definitely matters. Nowadays, digital machine of high qualities are available. For example, Ellingers, and they are all good machines. And even the Indian make, for example, Clarity, Medicaid, RMS, they are also routinely doing EG without any disturbance. But definitely a good quality machine. If, for example, nobody is using the analog one nowadays. So it all depends upon the better signal clarity. Resolution should be very good, and it also depends upon the electrode quality, which type of wet electrodes or dry electrodes or ready electrodes you are using, and sample rating and resolution are important. Amplifier quality is again very important. High quality amplifiers are there to low quality to boost the brain signals and all. Filtering and noise reduction is very, very important. So low pass filters and high pass filters are all there. Artifact removals are also there in these machines. So we have definitely one who is having a high-end machine. Definitely definitely it is not the machine, but how technician, how it is going to perform the EG, that is very, very important. And who is assessing the EG or report writing is again very important. As from pediatrician, we usually write EEG. That's all. Nobody writes what is the indication of doing EEG, what provocation you would like to do in this case. Nobody writes what drugs he is taking and what is the clinical suspicion. Actually, there must be a requisition. It should be adequate, informed to the electrocardiographer.
Yeah. So that's very important. Now, usually we do not pay attention to these things. We just write EEG and send them. So it's very good that you have given us so many directives that we must check the center that is doing EEG, the person who is doing the person who is giving the report. We must all pay attention to those things. So as such, so far we have learned that reporting EEG depends on so many factors that it becomes very difficult. And as a pediatrician on the receiving end, we just read the report and take the decision. That may be a very big decision for the patient. It may be small for us. So do you think that in future, it's not the neurologist giving the report, it's the AI that will give better report?
Definitely. But then you'd have to be, it is always in the medicine that you have to correlate clinically as well.
Definitely.
You have to correlate, definitely. You have to correlate the EEG finding with clinical. EEG depicting discharges and patient is normal. Do you like to start No.
Yeah.
So
vice versa
just to highlight a little bit on that, nowadays the machines, which is the modern machines, themselves, like even the Indian ones, they mark the spike, automatically mark the spike. There is a software in there, automatically the spike or sharp or generalized, whatever. But the machine doesn't know whether the child has moved or it is just cuffed or what is the difference. So, no, I mean, maybe in next 10, 20 years, AI might be that helper, but not at the present. No. The clinical is still the gold standard of these cases.
Can we start treatment without doing EEG?
Yeah, why not? If you are sure, like shown the child is having blinking and you are on the hyperventilation, you can elicit the seizure. You know it's a sudden absence epilepsy. You can start. Why not?
And one more question I have. In cases of breath holding spells, there are followed by convulsions. There are some studies, they say that we can give valparin along with iron therapy. Is it justified? And it has,
Sorry,
it
Dr.
has better results. I have seen 1 or 2 studies.
I'm sure you have seen 20 years back those studies, madam, or the oldest studies. I'm not aware of any recent study in this.
Okay, I'll
Actually, breath holding spell is it is not a seizure activity.
Yeah,
it is all due to anoxia.
Yeah.
And starting valparin is not going to help. Definitely, iron therapy will help, and other therapies which are recommended in breath holding spell. That is important.
I have seen 1 or 2 studies. I'll again check.
People used to give Gardinal before.
Yeah.
Before 20-25 years, when we were a student, we have to give the Gardinal, iron, all sort of for 3 months or 6 months like that. But it is not recommended.
Rather, Gardner was a drug of choice.
Yes.
Anoopji, which EEG is considered absolutely bad? जिसको देखते ही आपको पेशेंट को रिफर कर देना चाहिए.
Definitely, encephalopathies like bus suppression, hips arrhythmia, they are really bad for parents. Non-convulsive and convulsive status epilepticus, complete absence of brain activity, which is a flat going EEG. This is not a good EEG. Severe epileptiform discharge, frequent spike waves, like that, persistent and continuous focal abnormalities are there. So these are epileptic encephalopathies like the EG in LG. So these are all situations where definitely by looking to EG and clinical condition, as Sir has already said, that long-term anti-epileptic drug, prognosis guarded, all has to be counseled to the parents.
This brings us to another question, which so far we have been discussing EEG for seizures only. Which other conditions it is helpful in diagnosing? Means you have enumerated some more conditions where EEG can be.
Yes, hepatic. Yeah, there are non-neurological conditions like for example, hepatic encephalopathy, where we can have 3 spikes and wave, triphasic wave, like that. And
head injury.
Head injury, I don't know. CT scan, other neuroimaging modalities are very important.
So,
any sleep disorders.
Metabolic.
To declare death of a patient.
Sorry?
To declare patient is dead.
Brain dead.
Brain dead.
Yeah, this can be one modalities, but nobody does like that. It is an ECG which is important, and isoelectric ECG. Vinay sir, you would like to comment?
Well, there is a lot of debate still ongoing on this in India. In the Western world has settled that EEG, flat EEG with less than 3 microvolt persisting can be taken as one of the criteria, but it is not mandatory. No, but in India, still there is no guideline from the courts.
Dr. C.P. Bansal, do we have any questions?
Yes, I have 2, 3 questions, but before that, Dr. Mahesh has raised his hand since long, and that Dr. Dhiren Gupta. So let them first put their questions. I'll be putting my question in the end. Thank you. Over to Mahesh.
Thank you, sir. Am I audible?
Yes.
Yes.
Yeah. So basically a comment and a question. A comment is basically the critical case scenario where me and JN we work very regularly. One of the biggest utilities evaluation of unconscious child. So subclinical seizure can be picked up, which is very important. That's the only way we can really reliably pick up a subclinical seizure. A fetus epilepticus child who maintains to be unconscious for quite some time. To get a child with seizure, we give some anti-epileptics. Seizure stops. If the child doesn't show any activity within next 1 hour, there's a clear guideline that we should do an EEG to rule out a subclinical status epilepticus. Otherwise, we have seen in the olden days, after 6 or 8 hours, this child doesn't got up and then suddenly crashes into cardiorespiratory arrest because it was ongoing seizure and the oxygen consumption of the brain was so high that child could not sustain, the heart could not sustain. A question, there is always a paradox. When we get this refractive status epilepticus, our target is to achieve burst suppression on one end. So that's what we want to achieve. That's kind of achievement. Other end, Dr. Verma sir just now said, burst suppression is a bad brain. So that's one question you're going to explain us, good and bad. And second question, if you pick based on the abnormal EEG, then is there mandatory to have a periodic EEG monitoring after starting an anti-epileptic? Maybe a 1 month, 3 months, 6 months. Do you really need to do that? Or just clinically monitor and leave it alone? At the end of it, after 2 years, are you going to repeat? Is it mandatory? Is there a guideline to repeat an EEG that there is no clinical seizure at all in the 2 years? Two questions, burst suppression and second.
Regarding the burst separation, I would like Dr. Vineet to comment, but definitely this repetition of the EEG, it all depends upon how the seizures are under control regarding that drug. If the patient is already under control, there is no need to perform an EEG after 3 months, 6 months, 9 months like that. We can be left for 2 years seizure-free interval. And definitely, we would like, if the 2 years seizure-free interval is already there, we can have a repeat check EEG and then we can escalate the drug. If he's having a simple sort of epilepsy like selector sort, it should not be an epilepsy, as Dr. Vinay said, epilepsy. And so it all depends upon the clinical situation, clinical control of the seizure. Regarding I don't know whether there is a protocol, if there is a continuous seizure where every 3 months you have to monitor. It is not like that. Vinay sir.
No, nothing. Nobody recommends the repeated seizure. The repetition of seizure is required when you want to know that the child is having seizures and is still the EEG is normal. So is it a true seizure or not a seizure? So you do a video EEG to look for because a lot of young adolescents, young girls, they tend to have true seizure, true epilepsy, and then they tend to have non-epileptic events, and which their parent call, and the doctor, you just increase the dose or advise whatever you have done that, or the parent come and they describe the event because the child is intelligent enough to know what it is. So that's one situation. The other situation is when you are monitoring the treatment in the ICU, then yes, certainly you have to repeat that, and sometimes you have to do continuous monitoring. Regarding a burst suppression question, the same answer is the same. Why the burst suppression seen in the ICU setting, or is it seen in the outpatient setting? If it was in the ICU setting, then that is a good sign, means you are trying to achieve that burst suppression because the child was in status, non-convulsive or convulsive state, whatever it is. So burst suppression means the brain is now seems to be responding, and slowly it is likely to improve over the time, and then you will repeat, will not require continuous monitoring, and will slowly, as the child improves every day or every third day, you will repeat. If it is in the outpatient setting, then it is a danger. It is a very bad sign because the child is otherwise at home and having burst suppression. So that means he has got a lot of underlying pathology. Whatever is there, you have to investigate whether it is a metabolic condition, or it is a structural malformation, it is a hemimegalonic, whatever, I don't know, whatever pathology. So you have to investigate that quickly. But routine repetition is not required.
Thank you.
Dr. Dhiren.
Yeah.
Sir, it was wonderful talking. The one thing I want in future, right? One is that how to differentiate abnormal and normal. So initial part, say first 10 slides, we want more elaboration, a little bit slow mode, right? What is actually alpha type waves and beta, and what is normal abnormalities? I mean, that is very important. Means sometimes, I've seen the sleep, and when patient is awake, to a normal person, it may look like a seizure. So that I want a little bit in a slow mode, just one presentation only on what is abnormal, what is normal, and more emphasis in normal, right? One. Secondly, we are fortunate to have, all the neurological experts, so we need not to go to syndromes, and we have got available such as people always. But one confusion is always there, like there are two sets of patients. One is, I'm not talking about typical neurological syndromal patient. I'm talking about hepatic encephalopathy, where prophylactic anticonvulsant was there. Now patient is being discharged. Second, a patient of multi-organ failure who had one seizure because of multiple factor rather than epilepsy. Now patient is discharged on levopril. So how long levopril should be given in these type of patients? And third is the head injury, who had seizure, who didn't have seizure. So these patients were discharged and are now coming on follow-up. Do we need to demonstrate normal EEG after 6 months, 3 months, 2 months? So two questions, but should be the duration of anti-epilepsy when patient is absolutely fine. In non-epileptic, non-genetic, non-neurological, typical neurological cases. And second question will be for Dr. Bhushan about point of care EEG, which is available nowadays, because we have got presently super refractory status epilepticus in our ICU under general anesthesia. Seroflow is being given. So we have to read what is happening on the EEG. We want something based on AI, which gives an idea, okay, now the seizures are coming, some red mark comes. So at least the person who is there can, can raise a red flare sign.
So, Dr. Dhiren, I'm not dealing with the intensive neurology or critical care neurology, and I don't have any experience regarding treating such type of cases. I would like definitely Dr. Vinit to respond to your queries.
Vinit sir, आप बताओ.
Dhiren, you have a good team in your ICU, so you don't have to bother about those things. But certainly, but regarding your question, if at the point of care, if you are having a continuous monitoring, depends really what you are monitoring. You are monitoring a child who's in super refractory status.
Yes, sir.
Right.
Yes, sir.
And then you want to must be on the sedation, anesthesia, multiple anti-epileptic drugs, and medicine. Having one seizure, you do not need to respond. What you are trying to achieve is the background is normalizing, or have you achieved the burst suppression? These are the two things which you have to look for. Achieve that. If the child is having continuously seizures ongoing, you have to increase your sedation, the anesthesia, whatever you're using, ketamine, midazolam, lorazepam, whatever you're using, that you have to increase the dose, add another antiepileptic. In the super refractory status, your goal is to achieve the little normalcy in the background, which you can see distinctly from the seizure activity which is going on. And if you have achieved the burst suppression, that means this is the time when you have to scale down.
Yeah, no, Vinit sir, see, what my question is, like we have got, typical continuous EEG, which big monitor and everything going on, right? Later on, means now we are going to have monitoring systems from GE, and where around 10 lead EEG, 12 lead EEG is inbuilt. And they say it is a point of care EEG, right? So point of care EEG, so they set in something like a AI sort of thing. If this line appears right side, this appear line left side, so you can be aware, okay, there is something happening. And so you can call your neurologist, and this can be directly telecasted to the neurologist. So do you have seen these type of systems being used? So we are planning to install this system, because what happens, like today is Sunday, right? Fortunately, our fellow present batch is able to read all sort of EEG, but this is not going to happen uniformly in future. So we want an AI-based system which we can purchase and which can help people like me. It's very difficult for me to read the EEG and to know that what is normal and abnormal, right? So that is my weakness.
No, so I no, no, I'm not aware of that any process. They are in the process of developing. You are right. GE, Philips, everybody is developing those things, AI based, but nothing on the real world. We don't have anything like that, and I have not seen anywhere anything like that, even in the best of the institutes where I interact. So far, no. It is all the amplitude EEG has been there for last 20 years. The AEG, which people have been using. In the neonatal ICU, which you might also use in your ICU. Also. So that is a completely different thing because that even nursing staff can pick up that they are trained and they look if this is here, this is there are alarms because nobody is going to look at the monitor 24/7 who is sitting there. So that's the alarm. So what you are talking about is I think in the AI based system which automatically flags the whatever the line or color whatever that something has gone wrong and then somebody has to look at the interpret. But on the that is probably what you are saying is for the person, the neurologist who is coming in the next day morning and want to look at the 24-hour thing. So he's not going to spend 24 hours on that to look at that. He's going to only look at those highlighted, the color changes or the lines, which he's saying, and then will interpret whether it is really relevant or it is not really relevant. But at the point of care means when you are doing there, the only person who is present will be able to decide whether he needs escalation of the medicine.
This I am interested in.
Yeah, so no, we don't have anything like that. But certainly, if the AI is working all around everywhere in our life, so slowly and slowly you will see, and then they will give you a presentation once you have you seen that have they presented to you this kind of system which you want to buy?
Yesterday, I was attending a workshop on, totally dedicated to intensive neurology. So GE people presented with a monitor, and we are, about to change our monitoring system, whole monitoring system that is quite old, 10-year-old. So I was just interested that I want your experience.
No, we don't have any experience that, but certainly if something is coming up, then definitely it is worth.
Okay, sir. Second question: for how long you give anti-epileptic for those non-neurological syndromal patients where MRI and CT is normal, but you are giving levopril, now this most popular medication, after discharge?
No, it is if it is an acute symptomatic seizure, like in an acute setting, multi-organ dysfunction or whatever you had.
Yes, sir.
So recommendation is you can discharge if the child is young. You should not give any anti-epileptic. But having said that, people prefer to use it for 3 months at least. Even in the head injury, also the same thing.
So do you taper it or do you discontinue or do you do EEG after 3 months?
No need for to do EEG.
Okay, thank you, sir. Thank you. Anoop sir, it was wonderful presentation. You do so hard job, hard labor, and it has always been,
Anoop is known for it. Dr. Rakesh Bharadwaj, sir. Thank you for joining from Kurukshetra. You are not audible, sir. Not yet audible. No, not audible.
The speaker is on. I think volume is zero.
Not audible, sir.
अनूप के वीडियो की तरह
मीनवाइल राकेश सर का ऑडियो ठीक होता है। अनूप भाई, दो छोटे छोटे से क्वेरीज मेरे हैं।
जी
एक तो आपने बहुत बढ़िया, एज ऑलवेज इट वाज फैंटास्टिक प्रेजेंटेशन, एंड हार्टी कॉन्ग्रेचुलेशंस फॉर यू एंड थैंक यू वेरी मच। सर जी, मैं जो छोटे, मतलब ऐसा नहीं सोचना कितने बुद्धू वाले प्रश्न पूछ रहा हूँ। आपने बहुत अच्छी तरह बताया कि ईईजी की डायग्नोसिस मेनली क्लिनिकल है, पर हमें एक्चुअली प्रैक्टिस में क्या होता है कि जैसे फॉर एग्जांपल 2 साल का एक बच्चा है, उसको उन्होंने हिस्ट्री दी कि टोनिक क्लोनिक सीजर्स थे, और बढ़िया समझ में आया कि इसको एपिलेप्टिक सीजर्स थे और फीवर नहीं था। हमने एंटी एपिलेप्टिक शुरू किया। उसके बाद से वो हर 2 महीने 3 महीने में दिखाता रहा, सीजर्स नहीं आए। 2 साल बाद फिर उसका ईईजी कराया, चूंकि बिना ईईजी कराए ट्रीटमेंट बंद करना बड़ा मुश्किल है प्राइवेट प्रैक्टिस में, छोटी जगहों पर, क्योंकि पेरेंट्स पूछते हैं कि भाई क्या फ़ायदा हुआ इतने इलाज से कि या नहीं हुआ। और ईईजी कराया तो पहले वर्टेक्स एरिया में था, अब फ्रंटोपेराइटल हो गया, पर सीजर एक्टिविटी कोई हुई नहीं है 2 साल से। तो डॉक्टर विनीत भूषण सर भी कह रहे हैं कि 2 साल बाद अगर नहीं हुई है तो बंद कर सकते हैं, बिना, एज पर इंटरनेशनल गाइडलाइंस यू डू नॉट इवन नीड टू डू फॉर second EEG. But what if you have done it and if it comes normal, abnormal, not only abnormal, the seizure activity has shifted from previously it was at some other area, now it is at some other area. And
सर
unfortunately, such cases I have seen, one yesterday and one today. I have shared the screenshot with Banga sir also this morning. बताइए सर।
सर the actual में the change in the focus does not reliably correlate with the seizure frequency or the control. For example, if there is a seizure activity in one lobe and it is shifted to the other lobe, it suggests multifocal or bilateral epilepsy, not necessarily clinical change. And if there is a focal abnormality appearing in the new region, may reflect a broad epileptic network rather than there is a deuteration. So the change in the focus does not reliably correlate with the seizure frequency or the control. So you can so we can say that the change of focus is not necessarily a persistent of the or need for the further continuation of the anti-epileptic drug. It has to be monitored carefully after stopping the anti-epileptic drug.
तो बंद कर दें, मतलब 2 साल से कुछ नहीं एक्टिविटी आई है तो।
Definitely, there is no need. When the child is okay, there is no seizure. Only there is a change of the focus, which does not reliably forcing us to. It is a persistence of the seizure activity.
And what is the current protocol? Should we start with one drug or should we start with two drugs? If two drugs are being given, they should gradually be tapered off one by one, or both can be tapered simultaneously.
A single drug is very important. If it is already in one drug, we can continue it for maintain for one drug. And if the patient is already started on the two drug, continue with the two drug.
ठीक। एक जो बांगा सर ने क्वेश्चन पूछा था पर स्ट्रेच नहीं किया था, एक्टिविटीज अदर देन सीएनएस और सीजर एक्टिविटी पर से, जैसा अभी लास्ट कपल ऑफ डेज बैक मैंने एक पेशेंट के बारे में, आपसे तो बहुत बार पूछता रहता हूँ, एक पेशेंट के बारे में डॉक्टर विनीत भूषण गुप्ता सर से भी बात की थी रिगार्डिंग एब्डोमिनल एपिलेप्सी। बच्चों में जो एब्डोमिनल पेन होता है कई बार अनकॉल्ड फॉर, और उसमें अपन ईईजी कराएं एबनॉर्मल आ जाएं तो कैन वी स्टार्ट एंड शुड वी स्टार्ट एंटी एपिलेप्टिक्स? ऐसे ही
Definitely.
साइक्लिकल वोमिटिंग्स में, और कई बार हेडेक में देखा है न्यूरोलॉजिस्ट लो डोज ऑफ वेलपेरिन या टेग्रेटॉल शुरू करते हैं एंड पेशेंट गेट्स रिलीफ इन एडल्ट्स। आई एम टॉकिंग अबाउट एडल्ट न्यूरोलॉजिस्ट। तो योर कमेंट ऑन दिस ऑल्सो।
Abdominal epilepsy definitely needs, if there is a discharges and the pain is very severe in abdominal epilepsy. We have a patient of abdominal epilepsy, severe pain. with no response to any antispasmodic or every investigation was normal except for EEG, which demonstrated the discharges responded
Exactly.
with
Exactly.
antiepileptic drug and like that.
विनीत
your विनय सर आपका डॉक्टर विनीत
नहीं बिल्कुल क्या अगर if it is a abdominal epilepsy or clinical suspicion is there and EEG is positive, you should use it. No question. You should treat it.
which anti-epileptic should be started in that case?
Well, supposed to be focal, so carbamazepine. I prefer oxcarbazepine.
Okay, great. And about cyclical vomitings and neurological headache?
So cyclical vomiting नहीं है, but about 3 to 5% of the patients of epilepsy do present with a headache. And if you think the headache is the symptom could be because of that, and the EEG is fitting with that, then yes, certainly. Having said that, a lot of tension headaches do respond to valproate because this is a good mood stabilizer and modulator, neuromodulator. So they do respond to this, but that is not a first line in tension type headache. This is a third line medicine.
And we do give in a low dose also.
Well, low dose for epilepsy also you will start with the 10. I mean the lowest dose always, isn't it? So where the child respond, where the patient respond, that is good enough.
Deepak, you have been sitting so silently. Amazing, you have been silent since last 2 hours.
I'm
राकेश
listening.
सर आपका ऑडियो ठीक हुआ क्या?
Sir,
हाँ,
is it
हो
okay
गया।
right now? आ गया सर कि नहीं?
आ गया।
सर थैंक यू सो मच। सबसे पहले तो अनूप जी, डेफिनेटली सर हमेशा कुछ न कुछ बहुत अच्छा सीखने को मिलता है एंड वेरी एंटरटेनिंग। आई विश के इसको थोड़ा थोड़ा सा डिवाइड करके अगर 3 घंटे का टाइम हो जाता तो इट कुड हैव बीन ए वेरी वेरी गुड क्लास। सो एनीवे सर, कुछ थोड़े से डाउट हैं सर मेरे को। आई एम ए जनरल पीडियाट्रिशियन, नॉट ए न्यूरोलॉजिस्ट ऑफ कोर्स, बट आई एम डूइंग ईईजी, वेरी मच इंटरेस्टेड इन ईईजी। तो उसमें एक तो ये है सर, जो इलेक्ट्रोड प्लेसमेंट का आपने पहले डायग्राम जो दिया था, उसमें जो ईयर के ऊपर जहां हम T3 और T4 मोस्टली डिनोट करते हैं, वहां पे T7 T8 लिखा हुआ है। तो क्या वो
कहाँ पर किसमें लिखा
नॉमेनक्लेचर
हुआ
चेंज हो गया सर?
नहीं T3 T7 तो रहेगा ही रहेगा।
नहीं सर, T3 और T4 जो है दोनों साइड, और उसके पीछे फिर T5 T6 है, तो T7 T8 लिखा हुआ है। T7 T8 तो मैंने कभी कहीं पे लगाया नहीं कभी आज तक।
T7 T8 आई डोंट नो।
लिखा हुआ है सर, शुरू के डायग्राम्स में है। एनीवे वो T3 T4 ही होगा, मतलब बेसिकली ये है सर।
ज्यादा भी हो सकता है सर इलेक्ट्रोड पर। ये जो T3 T4 आप बता रहे हैं, T3 इज ओके है ना, T3 7 दिस आर ऑल लेफ्ट लीड्स, और T4 जो है आपका राइट में चले गया।
हाँ जी, नहीं T3 की जगह वहां पे T7 लिखा हुआ है और T4 की जगह T8
किसमें,
लिखा हुआ है।
कहाँ कहाँ लिखा आपकी मशीन में?
नहीं
कहाँ
नहीं,
कहाँ पे
आपके
लिखा?
आपने जो अभी डेमोन्स्ट्रेशन दिया उसके डायग्राम्स में, शुरू के जो डायग्राम है जहाँ प्लेसमेंट
अच्छा
ऑफ
अच्छा,
इलेक्ट्रोड्स है,
नहीं
फर्स्ट
नहीं वो तो
डायग्राम।
बाहर के डायग्राम है, उसमें वो नहीं है।
जी जी सर। सर दूसरा सिडेशन के बारे में था सर मेरा क्वेश्चन, के मोस्टली हमने तो स्लीप ईजी करना होता है, अदरवाइज तो बच्चे करवाते नहीं हैं, टिकते नहीं हैं।
जी
तो स्लीप ईजी के लिए जो हम सिडेशन देते हैं, तो मोस्टली हमें तो यही टीचिंग दी गई थी कि भाई मिडाजोलाम या डायजेपाम कुछ भी यूज नहीं करना चाहिए। तो पेडिक्लोरिल और मेलेटोनिन दो चीज यूज करते हैं, बट
बहुत है सर।
समटाइम्स
हाँ,
समटाइम्स नहीं होता सर, तो फिनार्गन यूज करते हैं। इज इट राइट सर? फिनार्गन अच्छा
फिनार्गन कर
suggestion?
सकते हो, आप कर सकते हो, पर सी द बेटर फैसिलिटी इज अवेलेबल, पेडिक्लोड इज अवेलेबल, melatonin is available, Noctura and all. Better to use that.
सर आजकल तो
फिनार्गन पहले यूज करते थे सर, बहुत पहले। आई डोंट
हम्म।
नो व्हाट इज योर ओपिनियन अबाउट डॉक्टर विनीत रिगार्डिंग
Uh,
फिनार्गन?
yeah, Finargan, some patients do not get sleep with this thing. So first time that you can try, no harm in doing Finargan. The only
सर
thing is the sedation goes a bit deep. That's okay.
आई एम यूजिंग सर पेडिक्लोरिल प्लस फिनार्गन, क्योंकि पेडिक्लोरिल की डबल डोज से भी कुछ नहीं हो रहा सर, कोई नहीं सोता।
तो अगर अगर एक डोज से नहीं सो रहा है तो दूसरी डोज में मिला के दें जी, ठीक है, यू आर ओके ओके विद दैट, नो प्रॉब्लम।
थैंक यू सर।
दीपक, दीपक,
I think, first of all, thank you for involving. Amazing presentation, Anoop, as
Yes,
always,
sir.
very practical. I don't have any questions left now with inputs, very, very clinical input from Dr. Gupta also. Excellent, sir. It speaks volume about both of you, Anoop and Dr. Gupta. What I learned today was, Anoop, you taught us various ways. You took the presentation from the very basics. I'm just mentioning what I felt and what I learned from a very basics to how the process various machines to how to identify abnormalities. Then you took us through various types of abnormalities, diagnosing how we diagnose. You then told us about specific diseases, case presentations. Amazing how you take it from the very basic, and you graded the presentation so well. Not that, let's be honest, not that I've learned the whole of EEG. I cannot learn in one day, but yes, my concepts are better than what it was a couple of hours back. Definitely, I would say that. Here we are treating a epileptic. We have various steps, various needs. First, a good machine, a good technician, as you have only said in your lecture, a good technician to do it, a good neurologist to interpret. We have done the first half, and then come the second half where general physician, general pediatrician like me, we have to treat after getting the. I'm sorry, 1 minute. So we have to treat the patient, and then selection of the drug. I'm sure that's a different topic altogether. And a couple of questions you've answered very well. And decision making is important. What drug to take? Dr. Bansal asked single drug or more than one at a time. How long to give? Those questions were also answered very well by you and Dr. Gupta. Though it was not the point of discussion today, but thank you for that, because you took a little beyond that what I was expecting to be discussed today. Very happy, sir, that you told us that clinical judgment is still very important, even if we have best of the facilities. We are lucky, we are blessed if we have all the investigation facilities. I was talking to Dr. Bansal in the morning that, do you think it's important that a EEG in children to be analyzed or interpreted by a pediatric neurologist? And he said, Deepak, it is very difficult to get one. So we are very blessed, we have one. But going back to the basics, what was the first word of today's presentation? The clinics still hold goods. I'm very, very happy, and thank you very much for giving us so much of information in such a short time. Thanks, Anoop, as always.
Thank you, sir. Thank you. Thank you very much.
thank you so much, Deepak. We'll be seeking your help to fetch new persons from there in future. May I request Professor Ghanshyam Das to extend vote of thanks? Are there any questions or comments? Swas, do we have any questions in chat box? Swas.
Should we ask Dr. Vineet his final thoughts?
Please, sorry. That is very important.
No, I think wonderful presentation, and I'm really impressed, Dr. Anoop. After a long time, I've heard you, not recently. There's a couple of comments only that the overdiagnosis should be avoided. It is better to wait and see the confirmation of the diagnosis before jumping on the treatment. The second thing is that the smart mobile have changed our, at least the pediatric neurologist or whosoever want to see the life very easy, made very easy. It was really hard where initial days to get the correct picture. Nowadays, see the video and within an instant of within few seconds, I can tell, and in almost 95% cases, the true seizure or it is not a seizure. And that has changed. And all parents should be encouraged to do whenever you're in doubt, even if there is, like you said, generalized seizure. The patient who has a breath holding spell, they will not tell the child has breath holding spell. They will just say the child was having generalized seizure.
and then you got confused and you started antiepileptic. Actually, they didn't felt that they didn't feel at all that the initial component was breath holding, which are that. So the detailed history is the first and gold standard, and then the rest of the things, the diagnosis, the videos, and then the treatment. The treatment part is the important from the parents' point of view, but for clinicians' point of view, it is more important to get to the right diagnosis and do not over. Thank you, Dr. Anoop, very much,
Thank you,
and
sir.
thank you, Dr. Bansal, and the whole, Dr. Ghansham, and everybody for having me here today. Thank you.
Thank you very
For
much.
those who do not remember, Vineet Bhai has, Dr. Vineet Bhushan has visited Gwalior about 20 years back when he returned from UK. I think within first year, you and Dr. Vikas Kohli have
Yeah,
visited Gwalior. Do you
yeah,
remember that?
yeah, 1 and 2 year or no, and again I visited when you that did that conference, and that was, I can tell
That
you,
was,
in
yes, that
yeah,
was the Pedicon in 2015 when you traveled whole
yeah,
night from
from
Kanpur to
Kanpur,
Gwalior.
yeah, exactly.
Right.
Thank you, sir. Dr. Dhiren, do you have any more points to add?
Unmute, Dhiren, unmute.
सर एक ही रिक्वेस्ट है, स्पेशल गेस्ट ना लिखा करो, बड़ा खराब लगता, मतलब सर हम तो घर के ही हैं, नाम ही लिख दो तो वी फील स्पेशल।
आगे से हम घर वाले लिखा
बाहर
करें, आगे
घर
से
के
घर
हो पर
वाले
बाहर
लिखे।
जाके हमारी इज्जत बढ़ा रहे हो
नहीं
कि
नहीं
हमें
नहीं
मजा
नहीं
आता है
नहीं
घर में
सर,
तुम्हारी इज्जत करने में।
नहीं नहीं सर, बस स्पेशल गेस्ट नहीं सर, हम तो घर के ही हैं।
वो क्या है, हम घर वाली नहीं लिख सकते ना। Dr. Ghanshyam.
Yes, sir. Good evening, sir. Thank you, Banga sir. Thank you, Anoop sir, for giving a wonderful talk on the EEG. And one more important thing, you said
Thank you.
artifact. In the EEG, they are saying few artifact. So we don't know what are the few artifact. You tell very well. Few artifact means बहुत सारे artifact होते हैं सर. हमारे EEG में क्या करते हैं लोग, only few artifact लिख देते हैं. Thank you, Dr. Bin Gupta sir. Thank you, Dr. Dhiren sir. And thank you, Bansal sir, Dr. God sir, Dr. Deepak Gora sir, for giving it valuable time and making this webinar very interesting. And in the coming Gwalior Academy of Pediatrics from this year, we have prepared a first Sunday webinar of this month and third Sunday webinar for this every month. We are planning first Sunday of month and third Sunday of month. So there are two webinar in a month, and topic will be decided by Dr. Sivansa sir and Dr. Ketkar sir, Dr. Dhonde sir, Dr. Banga sir. They are the core member for this event. Thank you very much for giving valuable time in the Sunday. Thank you very much. Thank you.
Take home messages we will try to prepare and send it like Dr. Mahesh Mote always prepare the take home messages and send it to the group immediately the next day or a day later. We will also try to do that, Mahesh Bhai. If we need your help, we will contact you. But we will try to make it and then send it to Dr. Anoop for accepting them, and then we will put in the various groups where we have shared the flyer. Thank you very much.
And please give your feedback on the performance, on the subject, on the timings, and all these things.
We are only 50 minutes overshoot.
50.
Thank you.
Thank you very much, sir. Thank you, sir. Thank you so much for the opportunity given.
Thank you.
महेश भाई आप म्यूट हैं. महेश भाई आप म्यूट हैं.
Thank you very much. Wonderful session, absolute wonderful. Always pleasure to listen to Dr. Learn so much every time, and he has got such a huge collection of cases. Call him on any topic.
Thank you.
Thank you.
Amazing. Thank you.
ओके, थैंक यू दीपक, थैंक यू धीरेन। विनीत भाई आपने बहुत
Thank
मजा
you, sir.
बांधा,
Thank you,
थैंक
sir.
यू।
Thank you so much.
Thank you.
अनूप भाई एज ऑलवेज सो इमेंसली ग्रेटफुल टू यू, थैंक यू।
Thank you. Thank you. Thank you.
गर्ग सर,
Yes.
राकेश सर, thank you for joining, thank you, thank you everybody, enjoy the Sunday evening.
Sir, before ending, we have got so many questions in our mind, and I think we'll have personally one-to-one to the Anoop sir and Dr. Gupta sir then. Otherwise, it will be late night today. So thanks from and heartful congratulations to all the